About this case.
Hi, it's my first day today, and so I wanted to know what kind of input you are looking from us. Like for this case, I think the court is like in the right because if you want to embrace motherhood, there are wonderful
Mhm.
options such as adoption also,
Mm.
and I think so. Like, do we share our stand on the case, or
Yeah, you can do that.
all right? So yeah, that's my stand. That I think the court is right here. Because autonomy and safety of a child are like two different things, and I think safety of fetal and maternal health just takes the higher pedestal, higher ground, and yeah.
Okay, thank you. Yes, Raju, you can go next.
I have a bit of conflict here. Like, what I feel is with the advent of like technology, which is like at the advent of advancements, every mother can experience motherhood, right? While taking laws into consideration, you just can't make it emotionally blind, right? At the end of the day, adopted child is still, adopted. Someday when the kid knows it, there's so much emotional quotient to it. Like, I think people just think about it purely and rationally. Like humans just don't work 100% rationally. There's also an emotional component to it, right? Do we deny the mother her like feeling her like feeling that she should not have motherhood? Like I think every mother who deserves it, every woman who deserves it should experience it, irrespective of the age. Yes, there are risks associated with an elderly primee, but had it happened naturally, let's say, would the hospitals have denied treatment? I don't think so. Every now and then, we just hear that this very old couple who people thought that they'll never have a baby, they just end up having a baby and they're perfectly all right. So in this case, I am a bit mixed. Court should not intervene. It is, I would say, it's directly at conflicts with the personal autonomy of the aforementioned Kavita Anand. I think she should have had the opportunity to go with it. Maybe yes, the technology of the times, might not help her conceive, or even if she did, might have fetal malformations. That might mean that the babies might fall in the support of the government, which will end up increasing the burden on the government. That might have been the reasoning now, but in the future, when reproductive technology improves, this particular scenario will definitely need to be reconsidered. That is my stand. I think the court is wrong. I think the court is wrong. People can give your opinions if you think that my opinion is not right. Thank you.
Yeah, thank you so much. That was insightful. Anyone else, or can we move on to the next case? Okay, coming to case 4. Anyone would like to read out the case?
Okay, I'll do it.
Yes, Vrinda, please.
Case 4, Surrogacy Age Limit Cases. Supreme Court 2025. Older couples with women above 50 who had initiated surrogacy before the Surrogacy Regulation Act 2021 challenged new statutory age limits, that is less than or equal to 50 for women. The Supreme Court held that since the couples had frozen embryos before the act came into force, they possess a vested reproductive right. Denying them completion, denying them completion would retroactively infringe their autonomy. The court exempted pre-2022 cases from the new limits, upholding reproductive liberty under Article 21.
Okay, thank you, Vrinda.
Sorry if I fumbled.
No, no, that's okay.
I hope.
Yeah. Okay, so this is a final case, and what went wrong here is the older, the couples who had already initiated surrogacy before the Surrogacy Regulation Act 2021, like for example, freezing eggs, we're facing the prospect of being retrospectively restricted by the new statutory age limits, that's women less or equal to 50 years. So this retroactive environment would disregard prior informed consent and investments in reproduction. Here the Supreme Court ruled in their favor, and it held because the couples had frozen eggs before the act came into the force, and they possessed a vested reproductive right, and the court exempted pre-2022 cases from the new limits, upholding the reproductive liberty under Article 21. And the Surrogacy Act 2021 sets age limit for women must be around 23 to 50, and for men it should be 26 to 55. So all these four cases illustrated that the Supreme Court's consistent effort was there to protect the constitutional right to reproductive autonomy, and often stretching the statutory limits of both the MTP Act and the Surrogacy Act or the ART Act to achieve justice. And the common thread is to focus on the welfare, dignity, and the choice of the individual, be it a minor rape case survivor or an older woman seeking parenthood. That's all then. Thank you so much. We'll have the next session now.
We now move on to the next session, Transgender and Non-binary Patient Care in India in Indian OBGYN, which will be moderated by Dr. Aqsa Shaikh and Dr. Sharin D'Souza. Once the breakout And now it is my privilege to introduce our distinguished speakers, Dr. Aqsa Shaikh, a professor of community medicine at Hamdard Institute of Medical Sciences and Research, a patient safety officer, a transgender rights activist, and a researcher working with marginalized groups, and Dr. Sharin D'Souza, a researcher and psychologist based in New Delhi. They are a queer, non-binary person working towards advancing LGBTQIA+ and disability justice using participatory research methods. We are truly honored to have you with us today, ma'am, and we look forward to your insights on this important topic.
Thank you so much. Totally my pleasure to be here again with the Student Association and talking about the topics which are very close to our hearts. And I look forward to the deliberations that will happen today evening. Thank you.
Thank you so much. I will now divide the attendees, the participants, into different breakout rooms for the discussion, for the peer-to-peer discussion of the cases before the moderators can give their insights to the cases.
Yes, so we would now invite the participants from breakout room 1 to present your findings on their assigned case. Any volunteers from breakout room 1? Yes, Neha, please proceed.
Hi, so the case was that a trans man, before going forward with his gender reaffirming surgery, wanted to cryopreserve his eggs. But the hospital refused by claiming that since there is no defined gender and that the ART law is exclusively for married couples, he cannot do this. And then the man went to the Kerala High Court, and the case is still ongoing. Now the thing is that the ART law, it is not just for married couples. It uh, under its umbrella, there's all people in the reproductive age group. Second, there is a defined gender. it is not like what the hospital said, that there is no defined gender. The man is going through a surgery, a risky surgery, to define his own gender, and denying him services can be seen as a form of discrimination. And if I remember correctly, there is a transgender person's rules 20. Uh, yeah, so it is a form of discrimination, and it is a form of violation of their reproductive autonomy. And our law is still pretty fluid on it, and there is no explicit law forbidding any trans individual to attempt to freeze their eggs or their sperm. And well, since it's the ongoing case, that's all from my end.
The participants from breakout room 2 can present your cases. Any volunteers from breakout room 2? Or anyone from breakout room 3 can also present your case now.
Can I?
Yes, Abhinav.
Yeah, in this case, 22-year-old non-binary individual seeks to undergo medical termination of pregnancy, abortion at age 19, but the clinic in which they are trying to perform this procedure or undergo this procedure asks for their parents' consent, despite this individual being above the legal age of consent. So this individual undergoes turmoil because they are not being respected, even though they are above the legal age, and they have to. I'm sorry, this slide changed, I think. And they have to call their relative, their friend's mother, sorry, as a surrogate guardian. So themes like I was talking about, what the eyes don't see, what the brain doesn't know. Certain cases like this might seem is very jarring when put in words, but I'm very sure like many such cases happen in our OPDs and we just don't know how to deal with it. So it just passes by our knowledge. Like in cases of MTP, Act, even in our classes, such scenarios were never taught. So you're never thought to think in these, scenarios. So in that aspect, from the foundation, I think changes need to be initiated. And another point to be put forth is the individual is quite young, the age to contribute to society. What this does when they are being denied their rights, it influences them as a person and also the society. Right? They are not able to perform their activities that a normal individual could, and they will also can be denied treatment due to these reasons. So this affects people systematically as well.
Thank you, Abhinav. Now that the cases have been presented by the participants, I request the speakers to share their insights on the cases.
Sharin, do you want to go first for the case number 1, which is Zahad and Zia's case and the birth certificate?
Yeah, sure. I think basically, as we know here, they had a child, and then they, at the Kozhikode Corporation, they had gone and they had demanded a plea asking if they can be made gender neutral, and they were denied that, and then they had to go to the court, etc. And the court basically, not just for the thought that this was a affirming ruling for the parents, but also for safeguarding the child and their well-being. Also thought that this would be an affirming cause. And under the law, what it says is, under the petition, what it says is it's that mm, not just is it the duty of the court to affirm under the Trans Act, but also this is something that in this case has can cause a lot of harm to the community. So that's why this was a very landmark judgment. Here clearly, like, I think a couple of things that we can see the gaps with respect to are one, that the documentation and registration systems within the medical system are really very gendered and binary and male and female with respect to everything. And this is not just forms, this is infrastructure, wards, bathrooms, everything. So there is a structural sort of gap in that sense. Then in addition to that, I think even after a plea, I think this was not accepted. But yeah, I think even within the community, what I'm hearing more and more is like gender neutral cards like parents and stuff can help not just the trans community, but also single parents, etc., etc. So in that way, this judgment has been really important in affirming the self-determination of the parents, the dignity of the parents, and also making sure that there is an intervention, that the intervention points out exactly the gap in the system and tries to address it. One problem that might come later on is, of course, that while the birth certificate is has parent, later on documents are going to have mother, father in schools, etc., etc., in other forms of documentation as they do. So then there is like a way in which some progress has been made, but later there is a structural issue of like how gendered the identification and registration systems are in government systems. I'll stop there. I'll come in if I have anything else to add. Yeah.
Thank you so much, Sharon. So, yeah, as Sharon mentioned, that this was, of course, a legal win, and recognition of the self-identified gender of the parents and documenting that on the birth certificate, because the birth certificate is a legal document, a very important legal document on the basis of which even your nationality is determined. And it's regulated under the Registration of Births and Deaths Act. And in India, currently, in terms of sexes, only two sexes are recognized, that is male and female. But then we have something called as intersex conditions or intersex variations. And until that is determined, the sex of the child, there is a provision that in the birth certificate, it can be written that sex not determined at birth. And that can be changed later on when the sex of this child or this person is determined. When it comes to gender, that's where the NALSA judgment comes into picture, which recognizes that there are more than two genders, talks about the third gender, talks about self-identification of the gender, and that's the legal basis of that. Now, what was the problem in this case? Because when we talk about ethical issues, we need to understand what are the underlying problems. The underlying issues of the problem here is that the sex and the gender is getting conflated. Because the person who is giving birth to the child, or what we call as the birthing parent, the law is saying it has to be called the mother. Whereas their self-identity is that of a man. They, in fact, have lived as a man. They identify as a man. Even maybe their legal documents are like that of a man. But the law is saying, oh, we must write their name as the mother. and vice versa for the other parent. And that is where the conflation of again sex and gender is coming to picture, because we are saying ki, okay, there's a birthing process, there is a person who is giving birth, and that person then must be called mother. Whereas mother and father, these are gendered roles in a way, or titles, and therefore, the court decided that we will use gender neutral titles like parents. But then again, that's like a half job done, because the next thing is they actually identify as a man and woman and not as non-binary people. And therefore, what if they want the names to be written like how opposite to what the law wanted, like as father and mother? So that would be another, legal progress that we really look forward to. Also, as Sharon mentioned, sometimes these one-off legal wins can sound very promising, but the law is so complex that once you change one law, you also need to look into the ramifications of the other things, like inheritance, naming in the passports, so on and so forth. And there's so many places where the parents and fathers and mothers' name can come. Let's say tomorrow they decide to get separated, and the custody of the child, so many things are there. And hopefully that this will act as a catalyst for changes, or maybe even reflection on the other laws. Yeah, thank you. I think we can maybe go to the next case now in view of time. Sharon, you want to talk about this case where ART?
I have not read it. I'll just quickly read it. I didn't have it.
Okay, then meanwhile, I think I can start. So, this was a case where a trans man says that they want to cryopreserve their oocytes before they start undergoing gender affirming treatment. And in India, a few years back, we have the Assisted Reproductive Technology Act, and the rules came for it. And the act and the rules, they have to be read with the other acts and rules, which are in terms of the Surrogacy Act and the rules, and also the CARA guidelines, or the adoption related guidelines, which of course come under either the Hindu Adoption Act or the Juvenile Justice Act. And these are the acts, which do not allow a single man to adopt a girl child. So this basis needs to be understood, because that's the basis for a lot of things that happened in ART and surrogacy. So a single woman can adopt a girl child or a boy child, where or any other sex, but a man is prevented from adopting a girl child. And using that logic, then single men are not allowed to opt for surrogacy or ART1. And similarly, women who are unmarried are not allowed to undergo that. So while adoption is allowed for unmarried women, surrogacy and ART, in that, there are issues. They don't allow that, because we are like, okay, it's a patriarchal society. What if tomorrow this woman is not dead? Then who takes care of the child? Though in adoption that's allowed, I don't understand why it's not allowed over here. So in both the cases, they want the intending couple or the commissioning couple to be a married couple, to be an infertile couple for who have been infertile in the sense not able to conceive for a year or more, and then married for at least 5 years in a certain age group, and all these conditions have been put up. So here, even if it was a single cisgender woman, probably they wouldn't have allowed it under the act or the rules if they were following it. Of course, a lot of ART centers don't follow the rules, but the law doesn't even allow the single unmarried women. It allows it for the divorced and widowed women, but not for never married women. Yeah, funny, but yeah, that's the logic that's being used over here. And the law constantly keeps on saying man, woman, man, woman, man, woman. So if someone has a trans ID, which is not binary, that means not as man or woman, but as transgender only, then there's no provision in the law which allows them for doing it. Similarly, the law does allow for the marriage of trans and cis people, but only within the binary categories. So, if someone is a transgender man and getting married to a cisgender woman, then they'll have to have not as transgender but a man as their ID. Only then that marriage can happen. So these are the things under which a lot of these laws are read, and because of which legally they did not allow this person to take advantage of ART. And even if they did ART, and later on they would not have been allowed to process it further or make use of those frozen oocytes, or even go ahead with surrogacy, because currently the law doesn't apply. And just to give you an insight, currently both these acts have been challenged in courts. This, of course, is the case in which the ART Act is challenged, and there's another case in which the Surrogacy Act is also challenged, and I'm one of the petitioners in the case where the Surrogacy Act has been challenged because it denies single women and trans people from commissioning surrogacy. Stein, any inputs from your side?
Yeah, when you were speaking, I also remembered recently using that same precedence of like men are not allowed to, single men are not allowed to adopt a girl child. That was used to justify denying it to a trans woman, I think, in the Madras High Court. So I think that was popped up in my mind when you were speaking. And I think in this particular case, like, I think the work that I've been able to do so far, I think when we talk about healthcare for trans people, it becomes this healthcare or that healthcare, like gender affirming healthcare or something else. But I think here, for instance, like the right to fertility is a part of being able to exercise gender affirming care at a later stage, etc. So I think to be able to look at the interlocking um, nature of these services, these demands that people make, and is also sort of, I think, really important to affirm people's autonomy, I think, in this case. So yeah, I think that's what I was thinking of when I read it. But yeah, we can move to the next one. Yeah. Yeah, I think I can share what I had started. I was in this group for the breakout. So I think here, I think Aqsa can sort of shed light more on MTP, but I think one thing that came across to me was that the young sort of non-binary person was being denied these services, or barriers were created not just because they were a young person, but they were a young trans person. And for all of those reasons, there was a lot of paternalism in how they were asking for like parents to be involved and insisting on that, even though there is no precedence for that. And these are things that actually happen to like young people accessing abortion all the time. I've been working on abortion access in a few organizations that I've been working on previously, and young people across the board say that some of these legally not mandated asks are often pulled out. And now more and more projects are also trying to mark out youth-friendly abortion services across the country, etc. And I think something like that for trans people also might be of use. So I think that intersection was something that particularly stood out to me. Then I think also wanted to add that the case now. Yeah, and I think the participant, like the person, had to get another person's mom, like any adult in their life, etc. And yeah, and I think that was also really a cause for harm. So I think what was also brought up in the group was something about inclusive language and how that's not something that's taught in medical education itself. So I think the two gaps that I was able to see was one, of course, like this paternalistic reading of the MTP and all of these things that are added on top, that are coming from this really conservative space. And then, of course, the fact that the people, the medical professionals administering some of this were also not not sensitized, not trained in providing care to a non-binary person. And I think we were basically discussing in that group, like, how can we bring about change in the system, and like medical education is one pathway, etc. But from just a hospital perspective, like, I was thinking about this program that's being done where trans people are being linked to different hospitals, which they can work towards reforming the infrastructure and sensitizing the people there. It's a pilot study. It's being done by SHSRC Kerala, and I think the results are yet to be seen. But like, there's a large scale sensitization and sort of a community based approach to involving trans people to reform their local health systems. So yeah, I think that looking at sort of agents of change within the hospital system also is one way apart from the courts and other things, I guess. Yeah. Over to you, Aqsa.
Yeah, thanks so much. I mean, I think I believe in the group or the breakout room, people did discuss about gender affirming care to be provided in cases of MTP. Just a few points in terms of the legal aspects is that in India, MTP is not, something that anyone can opt for, in the sense that there are conditions. It's a conditional access to MTP, and they're only under certain provisions it can be done. And this, of course, then gives power for misuse and also, power to gatekeep as to who gets MTP and who does not get MTP, whether it's legally authorized or not. Um, Second thing to understand is that the MTP Act underwent an amendment a few years back, wherein it's no longer a woman who is the sole gender who gets MTP, but it's made gender neutral, which means that any person, a man, woman, non-binary person, irrespective of whatever their gender is, can undergo MTP, and that's the Supreme Court's decision that has happened. The third thing to understand at the intersection is the POCSO Act, which says that children below the age of 18 years cannot give consent of any sort for sex, and therefore it becomes a mandatory reporting by the doctor or whosoever is the person in knowledge of it to the law enforcement authorities, which basically means police. And this I understand, irrespective of whether it's a non-binary person over here or it's a cisgender person, is a fear amongst the people that what if someone is hiding their age? How do I know that the age that they are telling in their ID is right? It's not forged. And what if someone is 18-year-old when they come for MTP, but when you calculate back, it seems that probably it was conceived when they were below 18 years of age. Then do we report it or not? So numerous cases have happened, and we do now have some kind of a legal precedence on it. So yes, below 18 years, it needs to be mandatorily reported under the POCSO Act. But then when someone is 18 years of age and comes to you for MTP, you don't have to do so much maths to find out what was the day when they had sex. Was that before 18 years of age, before their 18th birthday or not? No, we don't have to do that maths. And typically the courts are never going to catch the doctor for doing that, that you missed out on reporting it. Second thing to understand is, the approach where we are infantilizing our patients, even a 19-year-old or 20-year-old is considered a child, is true for everyone. It's also true for cis women. It's also true for trans and non-binary folks. And this is something that we need to, constantly work on, because there's a legal age. And of course, we can do counseling. We can ensure that they're taking an informed choice. but the decision of that person has to be respected. And in terms of confidentiality, in terms of, like the surrogate, because when a person comes alone for MTP, and the question is, oh, we always need someone to be with them. If not a spouse, if not their partner, then someone else has to be there. But again, that is not at all a legal requirement, unless it's you think it's kind of a medical emergency and the person may lose consciousness, and then we need someone to be their surrogate consent giver in that case. No, in most of the NTP cases, it's not that the case. So these are some of the extra legal measures that doctors take, thinking that they want to avoid the legal hassle. Oh, one case happened like that, one case happened like that. But when you actually go and see what happened in most of the cases, the court has always favored the doctors and not said, ki, oh, you should have done this extra legal measure also. And when it comes to a non-binary person, then of course the layer of discrimination and prejudice can even become more. So that is something that we need to discuss. And I think someone was mentioning while talking about this case, that these kind of cases are never discussed, in our case scenarios, in our studies, in our curricula. But then that is the need now, and really happy that SIMSOG is doing it. Thank you.
If anybody from any of the breakout rooms have any questions, you may raise your hands and ask the question. Yes, Abhinav, you may go first.
This seems like a silly question, but I had a doubt regarding adoption. As you're talking about a single unmarried man cannot adopt a girl child. Is what I'm saying correct?
Yes, that's the rule. Single man, yeah,
So,
unmarried.
so my thinking is, if an individual identifies herself as female, adopts a child, girl child, but then she wants to do gender reaffirming surgery, would she lose custody of the child, like per law? Like, I
No,
don't
no,
get it.
she won't. She won't lose the custody of the child. But you know what happens is, as a prospective adoptive parent, you need to apply through an agency to CARA, and then they do an assessment to look at certain aspects. And once that is done, and the legal transfer of the child is done within India, outside India, then after a few days that job is done. Now they don't follow up with that person. They don't care what's happening to that child, and the child may be actually outside India, where your jurisdiction may not even apply. So no, there's no precedence, or it has not happened so far that a trans man who adopted a child as a biological woman and then later on affirmed their gender as a man and therefore lost the custody. So no, nothing of that sort so far, thankfully.
Neha, you may go next.
Hi, so I wanted to ask that what is the logic behind allowing widowed or divorced single women to avail ART facilities and not just plain old single women? And are there
Mhm.
any ongoing cases where somebody has challenged this?
Yes. So I was mentioning the challenge to the Surrogacy Act is basically for that single, never married women are not allowed to commission surrogacy. So they need to first marry, get a divorce, and then they become eligible to commission a surrogacy, or their husband has to die, they become a widow. But jokes apart, yes, it's not allowed. And there is the only possible reason is that, the concern that what if this single person dies and there is no one to take care of this child. So if they are a widow or a divorce, then probably you have in-laws, because the child ultimately is the, kind of in the custody of the parental, I mean, the father's side. So then there'll be in-laws who can take care of the child. This single person who is unmarried, has no one, because woman is not maybe getting inheritance or financial support, etc. That seems to be the logic currently, though in terms of constitution, there is no legal basis for that denial. And that is why we have a strong case of, winning and getting that clause removed.
Thank you, ma'am.
Yes, Sai, you may go ahead.
Um, Actually, my doubt is regarding surrogacy in itself, right? Because the Act
Hmm.
states that it has to be altruistic. But
Yes.
it is not, right? Like it is always the act states like you can pay that person, but that person has to be like your close relative, and you can pay
Hmm.
for like the medical expenses, like the
Hmm.
travel expenses of sort. But the law states that there absolutely needs to be like no sort of financial motive behind you becoming a surrogate mother. But what happens in reality is topsy-turvy, right? Every sort of surrogacy, there exists that dynamic where like the mothers are like on the poorer background, the people who are hiring these people, they're on very rich side, and there are these shady middlemen who sort of like make sure that like the women who are undergoing surrogacy, they don't get follow-up. Recently, I'm from Tamil Nadu, so we even had like a discussion on this. There was a popular show where it was discussed a couple of years ago. The lady superstar, as they call it, she underwent surrogacy, and it was heavily criticized because it was stated that she went through it because she had affluence, she had money. So, can something be done about the surrogacy law, which will make sure that such things won't happen? Or what in the law needs to change? Because people are extremely blind to the fact that surrogacy in itself is quite a transaction of sorts.
Yeah, I mean that has been a discussion, and unfortunately, all these acts like Transgender Act, Surrogacy Act, TRT Act, if you see the time, the years in which they came between 2019 to 2021, when we were all in lockdown, right? And so there was not a great amount of public consultation for framing of these acts and their rules. Most of them were done in a lot of hurry, and the various stakeholders were not consulted. So, for surrogacy, there has been a lot of resistance to the idea itself of surrogacy, calling it exploitative and too interventional for something which is not life saving. And therefore, it is having a parallel trajectory similar to the organ transplantation. So in organ transplantation, we had seen that previously the transaction was allowed and compensation was allowed. And then the organ donation also became altruistic and only allowed the close family members or swapping of the donors with zero, financial transaction allowed. In case of organ donation, of course, since it was a matter of life and death, people could become very desperate to get organs and would do beg, borrow, steal to somehow get that organ. And a lot of malpractices that happened, in which also involved the doctors. In case of surrogacy, also we have certain cases where a lot of, there would be also surrogacy tourism, in the sense that a lot of foreign couples would come to India, would hire very low privileged, marginalized women as people who would be the surrogate mothers, um, pay them a very less amount, and then go back. There's a movie called Mimi on the topic also. And to protect this, then the act came, but then the act kind of overshot itself by saying it has to be altruistic. and with no transaction, and then putting these conditions that only certain people can commission surrogacy. So, yeah, I mean, this is an open debate and discussion on whether it should be altruistic or whether financial transaction should be allowed. And I would probably say that the jury is still out on it. Of course, the law says it has to be altruistic. But in terms of even the ethical conversations, there is no one agreement on whether it should be altruistic or whether it should be not there. Just for example, in some of the European countries like Italy, surrogacy per se is banned, which means even altruistic surrogacy cannot be done because they say it's not a life-saving procedure. You may remain childless if you are not blessed with a child, or you may adopt a child if you get a chance, but you don't need to have surrogacy. So we have these kind of views across the world, and there are places where it is still not regulated also. So sometimes when the government tries to regulate something, the means can become very restrictive in terms of who is allowed and who is not allowed. So yeah, that's thank you for raising that point.
Thank you so much, ma'am. We could now move on with the next session. And thank you, Dr. Aqsa Shaikh and Sharin D'Souza, for sharing your valuable insights and perspectives on various aspects involving transgender and non-binary patient healthcare. We truly appreciate the valuable work you continue to do in advancing rights-based and inclusive healthcare. Thank you so much, ma'am.
Thank you so much. My pleasure.
Thank you. Bye-bye.
Bye.
Now it's my pleasure to introduce Dr. Vanita, who is the Medical Director of Sunrise Laparoscopic Center, Ashoknagar, Chennai, a distinguished figure in the field of minimally invasive gynecologic surgery. She currently serves as the South Zone Coordinator of FOXY Endoscopy Committee, Managing Committee Member of OXY, and the Joint Treasurer of TNIAGE. We welcome you, ma'am, for this insightful session on breaking bad news in cases of congenital anomalies and stillbirths.
Hi, good evening to one and all. At the outset, I thank the organizers for the opportunity.
Yes, ma'am, we may begin.
Yeah, see, the topic given to me is breaking bad news in case of congenital anomalies in stillbirth. See, when we really look at a woman walking into a clinic for a pregnancy till today in India is considered only a physiological phenomena. Okay, it is that babies are delivered from days of Adam and Eve. Every woman goes through a pregnancy and they expect only a very good outcome. Nowhere they are ready to accept a bad outcome. So they are not ever willing to take up this. This is something which we need to keep in mind because many of the pregnancies, though it's a physiological phenomena, are associated with pathological causes. See, you may consider it as a pregnancy and delivery, but this woman may have a PIH, may have a GTM, may have a baby with an anomaly. All these things are going to definitely change the outcome of the process. So it involves like staying with the patient connected right from the day of conception to delivery, and in the event of anything untoward, you have to guide them. That is something basically we need to understand as doctors and be with them, accompany them, guide them, but not take decisions for them in the journey. That's something which is very, very pivotal for us. When we talk about bad news, it's any piece of information which is going to adversely or seriously affect an individual. If she comes to me, say, for having a nice chubby baby, taking back home and having all the celebrations, and I'm going to tell her, you have an anencephalic baby, you think she's going to really accept it? She's not going to accept it. So the first question is, why did this happen? Why? What? How? What are the ways by which it can prevent it? If it is diagnosed right on time, suppose you miss the diagnosis, she comes to you late, where the viability sets in, and that is the time you're going to be bombarded with questions. So this is by itself a very difficult, way of handling things. Breaking bad news itself is a very important art where you have to strike a fine balance between how much to tell, how much to disclose, and what not to pour out too much. It's very relevantly you have to speak, right to the point so that the patient gets and understands what is very important to her, and not just give her too much of unnecessary information which confuses them. Lead them to a path. As I said, don't take decisions for them. Allow them, show them the options, and you have to get the word out of them. That is a special art. Okay. There are ethical and medical legal implications, because sometimes, you say like you're seeing a patient in 36 weeks with complex congenital anomalies, which could have been picked up at 22 weeks. The first question will be like, why was it not picked up? So you can't say that particular doctor who has done the scan at 22 weeks has not done it, so it's not my problem. So you have to also understand every word of yours has its own medical legal implications before you utter a word, and you have to really be guarded and guarded when you do this. So you can't withhold any vital information. In other words, you also have to talk very clearly, non-medical jargon about the prognosis. Every single patient has the right to know. What happens in most of our societies is they will say the mother will not be in a position to handle, so you please don't disclose with her. And it's finally the mother who comes, and sues you, saying that, why was I kept in the dark? Please don't succumb to the family saying that, don't disclose it. She's not in the mental state to accept it. She's got a very fragile heart. No such things. Everything has to be disclosed to the patient and the family in a proper manner. Can I have the next slide, please? So what are the barriers? Many a times, as doctors, as clinicians, when you get a report, you might not be very sure about the incidents. What are the, after effects, how to prognosticate. So when you're not sure of anything, please don't be in a hurry to go talk to the patient. Gather the information. You go through the medical records. Sometimes, it will be like, she would have had 2 abortions. You will not be aware of it. You will go say, this is the first pregnancy. That is when they'll say, we had 2 abortions. So first, sit, collect the data, get yourself calm, composed, integrate yourself properly, gather all the information, assimilate all the information, make sure of what you're going to address, and then start. The next thing is, when you're going to break a bad news, a society never wants a bad news. Okay, even for a terminally ill patient who is on a ventilator for 10 days, they expect miracles to happen. So when you're going to go say this patient is not going to see the end of the day or not going to see the dawn tomorrow, they will not accept it. So you have to, fine tune their minds and make them slowly accept the process and come to terms with reality. The doctor may feel that he's incapable of managing the emotional reactions resulting from breaking the bad news. That is where the entire family and your medical fraternity comes. So this is a place where your ASHA workers, your staff nurses, or your counselors, all of them come, because the doctor hardly spends a few minutes in the consultation room with them. These are the other workers who really spend more time with them, get to understand their cultural background, get to understand their expectations, and get to understand what sort of patient and what they really want. So they should also become a part of the breaking bad news sessions when you do it. Okay. The doctor might have presented over, sometimes whenever you get a patient, please don't be over optimistic in telling them, this is nothing, we will do it. This is a miracle. No, never, nothing. Whatever is the matter, please put it black and white to the patient, which will go a long way, not just as a verbal communication, but also as a written communication. Document it and always get it signed by the patient, the couple, and 1 or 2 attenders from the other side. This is something which will go a long way. Next slide, please. Who does it? It's always a senior consultant or the consultant who has been, associated with the patient over the process, who should talk. But sometimes if the doctor is, like attending to something very important with that particular patient, you can entrust another senior nurse or a member of your fraternity who is capable of answering. It has to be one language from the entire team. Every single person cannot be able to speak what they runs in their mind. It has to be one language, one intonation. The same empathetic attitude should remain everywhere. Being honest, empathetic, and sympathizing with the patient helps you, tide over the crisis, and also the patient tends to accept the bad news and gets into it very easily. Next slide, please. The do's and don'ts. It should not be a didactic lecture like where you just go start vomiting everything. See, for example, I have a baby born with ambiguous genitalia, or I have a baby born with TOF. I have a baby with a complex cardiac anomaly which cannot be identified in the prenatal scans. I just can't keep going on talking. So first thing, we need to make the patient sit. We need to make that sit. We need to, think about what runs in their mind. Allow time for them to discuss, allow time for them to get into the sole crux of the matter and make sure they have understood. Please do not use any medical jargons. Okay. Even if you're going to say anencephaly, if you're going to use the word anencephaly, they will not know. You have to tell them the skull bone, which is supposed to be a protecting for the brain, is not available, is not developed properly. So these are words. So then it will be like, why has it not developed? So that is when you should bring in folic acid into the scene, saying that there is nothing totally preventive, but it is said that giving folic acid substitution can somehow some amount reduce the risk of neural tube defects. So again, don't say if you take folic acid, you will not get it in your next pregnancy. You can say you can reduce these risks. Very simple. Ensure privacy and confidentiality. Don't talk to anybody in the corridor. Don't talk in front of another patient, because what is their problem is solely their problem. Even if you want to involve the family, you have to take the concern of the couple as to whether they're okay to have the sisters or the brothers or the parents in the part of discussion, because sometimes that itself could be an added problem. So always talk to the couple first and find out from them whom they are comfortable. Keep a glass of water, give them tissues. Holding the hand and giving tender loving care goes a long way in this, when you break a bad news. Pause for a minute, look at the reaction that they have. It can be denial, it can be grief, it can be anger. First thing that comes is denial. Okay, then comes anger. All that you must be prepared to handle everything. So then listen to what the patient says, which is very, very, very important. Never try to hide the truth, even if a mistake has happened. We need to make them understand this has happened this such a way. We are here to set it right, and we need to make them understand that we are not God, we are just human beings. Okay. Never give a false reassurance saying the time frame saying that in 12 hours it will be right. Once a baby is born, we can turn the world around, nothing like that. Never withhold information and don't overload the patient with more information. Next slide, please. We have various protocols like the spikes, ABCD, breaks, future, sunburn. When we go through any of the RCOG counseling sessions, what they routinely use is the spikes and the breaks. Can I have the next slide? Next slide, please. See, what are the goals of this? It's just to collect information from the patient in order to develop an idea regarding the patient's existing level of knowledge. Sometimes, you will be telling the patient that you have complex cardiac anomaly or you have a neural tube defect. You would keep on telling that, but the patient's mind would be like, once a baby is born, we can correct it. So that is the thing which you have to tackle at the beginning, saying that whether it's compatible with life, whether it's not compatible with life, what is the pathway to normalcy. These are all factors which you should explain very clearly to them. So first thing, tell them what it is in non-medical jargon and ask them what they understand. Okay, and then what it is. So make that matter get into their heads in a non-judgmental manner without affecting their psyche, because you need to understand the baby is their unborn treasure. Everybody wants to have a nice baby. Everybody has the rights to have a nice baby. So that's the unborn treasure to which the mother is already connected. She's feeling the baby's movement. She's enjoying every day with the babies and she's longing to have it. So something untoward, she's not going to take it very easily. All of us are very unhappy even if, one dress of us gets stained. So imagine a baby. So we have to be very empathetic in our approach to these moms. You have to really have an important goal of the treating team is to provide proper psychological support. Giving the psychological support and giving them the genetic counseling as to why it has happened, whether it will recur in the next pregnancies, and how to go about with them. Asking them to meet the cardiothoracic surgeon or the pediatric surgeon or the neurologist as to what are the outcomes, how to prognosticate it, will help them gain a lot of knowledge thanks to Google and the AI tools that are available today, which loads them with more information than needed. So sometimes you get patients with half-baked knowledge who are going to, bombard you with questions. So it's always better when you sit for a counseling session, you are also sure of the numbers, the prognosis, the associated symptoms, and all the other things before you sit for it. Before you go, develop a treatment plan, taking into consideration the outcome and also the financial burden on the patient. Because finance is something in India which is a real burden to the patient. If it's in the government setup, it's okay. But in the private setup, you have to really think about it because it's not the NHS which pays, it's the person from the pocket, patient's pocket. Okay. So all that also has to be kept in mind when you take these things into consideration. Next slide, please. So this is the Spikes protocol, which talks about choosing a setting which is private, comfortable, and non-threatening. So you can't sit in front of an OT with all lights, gadgets, 10,000 equipments. It has to be a silent room with the patient one to eye. Make a eye contact. You know, when you're talking to this patient, suddenly don't go pull out and start talking about another patient in the ICU. Don't start talking about a laboring mother. That 20 minutes or 10 minutes or half an hour is totally dedicated only to this particular patient who's going through the trauma, okay, the couple. And you have to have the perception, uncover what the patient and the family thinks is happening. Invite to ask the patient, what else do they want to know? How can I help you? Is there anything that I have to do? Give them the knowledge of what they want, emotions, respect their feelings, especially when you have a congenital anomaly and you say, I want you to send the baby to autopsy for you to know what's happening. That's a very blanket statement, you know, very something. See, do you even know, like many of them don't like to autopsy even an adult. So you say, if at all you want to know what is the outcome, you have to do an autopsy. That's not the way. It has to be very polished, sweet tongue words like, it may throw some light on the future outcome for the future pregnancies. I do respect your rituals. We do respect your religious concerns. If you say X, we would get things arranged for you. Tell them the pros of having the process done, and always treat the baby like a newborn baby, which is alive with all emotions. Okay. Don't look at it as a subject with no life. And then at the end of it, summarize. Most importantly, ask them what they have understood and whether they've got you through the right way. Because even in a patient, you know, like who is really going through a CPR, we have the contender standing outside and asking you, is everything fine? All of us know in a CPR how much is going to be the outcome. They are through the terminal phase, but then the answer is, will the world turn around and will it become rosy? So we need to understand the patient's psychology and we need to handle things the same way. Next slide, please. So this is about the Spikes protocol. See, very polished words, whether it's in English or whether it's in your own native language, it has to be in a way that doesn't provoke the patient, which empathizes the patient, where you have a lot of sympathy and you are also on the patient side saying that this is something which is untoward, this has happened. We are here to help you go through this, tide over that. These are words which will give the patient a lot of courage, saying that she's not going to take the journey all alone. Next slide. Yeah, exactly the same thing. Next slide. This is another protocol, similarly, where you understand the background of the problem, have a rapport with the patient, explore what are the things that you have, outcomes that you can, and what treatment options that you have. You announce to the patient, kindle the thought in the patient, and summarize finally. See, when I say, the first thing they'll ask you to put the ball in your court and say, what would you do, doctor? You should just tell them the options. It's a cafeteria approach. Put all the things in front of them and say, this has a prognosis of this, outcome would be this. Option B has a prognosis of this and the outcome to this. Option C. We are here to help you through your choice. If I were to suggest, I would go with this, but still options are in your court. You have the rights to choose, and I would be there to do the best out of your choice. This is the way you will have to address it. Next slide. So exactly the background, establishing the rapport, exploring about the condition. Sometimes, you know, we may not even know what it is because you will have a very rare genetic disorder, which every gynecologist may not even know. But once the report comes, you have a severe, you know, Korean Miller sampling result or your amniocentesis result, the patient is going to keep asking you. So before you sit for a counseling, please do your homework, read through everything, and then sit for the counseling. Next slide. See, first thing, don't go right hit their mind and say, you have a baby who's like this. No. Please tell them, I know you've been through this. It's not the way it has to be. There are some problems. We'll have to address it. So polish your words, select your words very judiciously. Give her time to react emotionally, whether it's anger or refusal. You have to give her time. Ask her who would be her best companion. Give her a cup of water, give her tissues, give her time. And don't try to push every information in one sitting. If she's not okay, you can always tell her, I will just break now. We can always sit back in the afternoon, or we can sit back after a couple of hours. We can also do it after a day when you are mentally better. These are the ways by which you'll handle. Okay. The next one. Again, we have another protocol, which is the ABCDE. You have to have a preparation, build a therapeutic environment, communicate well, deal with the patient family reactions, encourage and validate emotions, which is very, very important. Next slide. See, when you do breaking bad news and congenital anomalies, first thing, as I said, always remember the patient has an emotional connect to that unborn child. Many of the children are, though they don't know the gender, they assume and presume that it's a particular gender, they are named in utero, they start building dreams, of sending the child to college, they start building dreams of having a child who's going to get married. So in our society, that's a long way to go. They start building wealth even before the child is married, formed in utero. That's a way it is. So you're going to go trash and slash their dreams. That's something you need to. So it has to be done in a very soft manner. You have to then talk to them about the nature of the anomaly, whether it is correctable, not correctable, whether it's compatible life, whether she needs a termination, at what age it has been diagnosed. The current MTP Act, which is amended in 2023, must have a knowledge whether, if it is a small anomaly, like you have a congenital talipes virus, which can be managed with just a strapping or a small surgery post-birth, natally. So these are the things where you will have to give them the appropriate reference, or you should ask them, this particular patient requires, baby when born requires a pediatric orthopedic surgeon. You have somebody in your family or friends to whom you would like to refer to. Don't just say you go see that doctor in room 201, he will help you. That's not the way it should be. If they have somebody on whom they have a lot of trust, let them go, let them do it. If they don't, then may I suggest that is the way you have to do. At the end of the day, when you finish your counseling session, always give time, record everything, and then you put your signature from the patient and the attendant also. You take a signature, do it in duplicate, have one copy of that with you, one copy with the patient, and please tell them these are the reports. You're always free to go take a second opinion for you to come to terms with reality. This one word will give you a lot of belief from the patient side, because if the patient understands that you're very transparent, you're not hiding, you're ready for another discussion with another doctor who's equally qualified. Okay, these are all things that you should do when you're doing the counseling sessions. Suppose if the child is born, and then you have to tell what is the nature and outcome of treatment, what is going to be the financial burden, what is going to be the hospitalization, what is going to be the outcome, is it going to be a long-term burden, or it's going to be a short-term, one-term correction. So you have a PUJ obstruction. One simple correction, by the pediatric urologist is going to help the baby live a near normal life. You have a polydectomy, you don't even have to bother. A plastic surgeon is going to remove it and the child is going to be near normal. But if you're going to have a spinal bifida with a urological problem, that is going to be lifetime. She's going to all the time have a catheterization problem, So these are all factors which you should slowly counsel the patient and sink it into the mind. And, over a period of time, the key person in the family will be aware of everything. She will be able to tell the others in the family that I know my baby has such a problem. I am accepting to go through this because it's my baby. This is something which you have to do. Concern to continue the pregnancy, abort the pregnancy, whatever it is, should be taken in black and white after explaining everything. Next slide, please. Again, we have the classification, which can be based on the developmental process. Here, we have to always think of the syndromes. For example, you think of Down syndrome. Okay, it has multiple factors like a increased nuchal translucency, absence of nasal bone, echogenic foci. A single marker may not be of any use, but when you put together all these, you have to sit with the patient, tell her the need for further investigations. These are all screening tests. Your final test may not even show up anything. So the turmoil and the mental problem that the patient is going to go through during this process is really going to be too much on the patient, but you need to stand with her and help her till the delivery is over. Again, on the severity, it could be major, minor, or moderate. Again, based on the system, anything on the CNS and CVS, we are really scared. Sometimes with the infectious diseases like your congenital rubella syndrome and all that, the anomalies are much easier to tackle. Next slide. As I said, you have to talk to the patient about the type of anomaly, the incidence of the anomaly. If it is a rare, whether it's going to recur in the next pregnancy is something which we have to think about. Whether it's compatible with life, a very, very clear explanation of what it is in the sequelae, clear explanation of the treatment prognosis, with the entire team, not just the gynecologist. The gynecologist has to be there, the pediatrician has to be there, the geneticist has to be there, the pediatric surgeon has to be there, cardiothoracic surgeon in case of complex congenital cardiac diseases. In case of urology, you have to have a pediatric urologist and a nephrologist. So it's the entire team. After that, within the limits, if they still want to terminate, you have to be with them, go through the termination process, and explain to them about the need for autopsy and genetic screening. Next slide. See, where are the times when you can really go through and see these on routine ultrasounds done at 11 to 14 weeks? You can pick up most of these anomalies like neural tube defects and down C screening and all that. Again, the next window is 20 to 22 weeks when you do a routine anomaly scan. Some of them don't show up at the time, like renal pelvic cases where you pick up around 28, 32 weeks. Sometimes, the patient would have had like one of those conditions which is talking in the room number one, an anencephalic baby in the tribal who has not at all undergone a scan. She just comes at 36 weeks and you pick up multiple anomalies. These are also sometimes happening. There are times where you just are caught unaware at birth. These are factors which can happen to any of our patients, and we must know how to handle them. That is only, as we all say, it's tender, loving care with empathy and sympathy, which helps the doctors sustain and survive through these sessions of breaking bad news. Now, I think we can go for the case scenarios and discussion. Do we have any questions to discuss? Either it should be very clear or that I don't have any questions from the audience, or I was totally off the track that people did not understand that what I spoke. Yes, I find Dr. Ananya asking a question.
Good evening, ma'am. Ma'am,
Good evening.
how do we break bad news if how to counsel the patient if like variants of uncertain significance they show up on the scan?
Can you just repeat it, please? Can
How
you
can
repeat?
we go ahead with yes, ma'am? How can we go ahead with counseling the patient if like variants of uncertain significance they show up on the scan?
Yeah, see, sometimes you have variants of insignificance. Okay, like as I was already telling, a simple echogenic foci in the heart, echogenic button. These may be a normal variant also, but you have to get a single umbilical artery. These are all conditions which could be normal variant or a part of a syndrome. So once you see something like that, never stop with yourself. Always ask for a second opinion to somebody else who's a fetal medicine specialist, and then tell them this is a isolated finding per se does not point to anything. In the event of other associated factors, we would still consider it normal. However, never put a full stop in medical practice. Keep everything in comma, saying that we'll have to wait to see when the baby is born if everything is the right way. We need to understand all these are investigations which are only imaging, where it is done through the maternal abdomen, through the liquor into the baby. So there is a false negative and false positive predictive value. However, with high-end imaging, with our 3D, 4D, and the associated investigations, the risk rate is definitely reduced. An isolated finding, as the finding needs to be documented, but you don't have to, push the patient to say, yes, you have this at every visit. See, sometimes, like lateral ventriculomegaly is something which you really pick up, but that is an isolated finding. The baby need not really have a shunt problem. So you have to keep documenting it, take a second opinion, ask for more and more scans, frequent scans compared to what another baby. So the patient also understands it, and thanks to a Google and other AI, they also go through it. Definitely most of them go for a second opinion, because today we have a doctor in every house. Okay, irrespective of the specialty, they go, they ask, and they also come with their homework done, sometimes much better than what we do, because they have done a thesis on it. For us, it's just a case. For them, it is a life. Okay. So when you have a variant, don't throw more light when it is an isolated variant.
All right, ma'am.
Yeah.
Thank you, ma'am.
Thank you.
I see Sneha's hand is up. If you want to go ahead.
Yes, good evening, ma'am.
Good
Uh,
evening.
First of all, amazing, very insightful session. I don't think anything like this has been covered in the past 3 years of my medical education. So thank you for that.
And I'm
And
sure this is going to go a long way in your practice because we have a pressed couple, the IT couple, who are, like expecting everything on a platform today. So we need to really moderate and do things according to their wishes. So whether you practice the right way or not, delivering the content to them the right way becomes very important.
yes, ma'am. And ma'am, my question is that all these protocols and everything you've just told us, is it possible to do this properly in a government hospital setting? Because
Yeah. See, it is again a team approach. Together, everybody achieves more. See, even in a small setup, what we do is we tell them everybody cannot raise their voice and everybody cannot start giving their opinions. When you have a patient, it is a team. You have a senior doctor, you have a junior doctor, you have one nurse and a counselor. Only the four people should be addressing when it comes to counseling with regard to that. See, forming a team, getting them to speak the same language sounds very difficult initially, but after a few months, it becomes a protocol. Okay, so when you have, there's something called as a turnaround time. When you have a patient with an abnormal scan in my hospital, if you see, the patient does not get the report. It has to come to me on my table. So even before the patient comes, a copy of it, when it's there with me, I know this particular patient XYZ has this problem. She's going to come and discuss to me. So I would have done my homework. So nobody is allowed to talk. Only a particular group of the staffs are allowed to talk. It sounds very difficult. See, the way it comes around is by doing drills. When we gynec, what we do is when we have a PPH, we have a drill. Everybody is assigned a job, so they know what job they have to take. See, one person will assign the job of being empathetic, being by the patient side. One person will speak properly. My junior doctors, sometimes they have the inhibitions to speak to the senior doctor. My junior doctor would stand outside and say, "Did you understand what madam spoke? Do you need more clarity on which are the areas?" So if she is able to get to the tune of the patient and make it more clear to them, she would. Otherwise, she would say, "Please wait for a minute. I will get another appointment where we can go back to madam and discuss the same." There are times when the same couple will come to you n number of times because it's a mental trauma and the human mindset of thinking that if something else could happen to them and if they can just do wonders, turn around tables to get back to normalcy. See, they would be wanting to zone for your antiretroviral therapy or if you're your financial counseling in your IVF, you're able to do it, right? Similarly, it's not going to be very difficult. One person who has little knowledge of genetics, who has little knowledge of outcome, or when you can just get things done on a paper and then talk to them, not anything out of the paper and stick to the paper, it is very easy for the entire team to speak. The most important is every single person should not voice out. Has to be one proper team. You have to give an appointment. First time, second time, third time, doesn't matter. Even if the silliest of the questions, we need to answer. Because I've had silliest of questions like after Mr. Abortion, people come and ask me, "Can't you give a defib and make the heart beat?" You do it in adults, why not in the baby? Because that's been shown in a couple of two Tamil movies. So people keep asking you all that. So you have to be very empathetic to them. Make time for them even in your busy schedules. Or patients do accept you. Tell them, "See, I'm amidst something. Please give me 10 minutes so that I will sort out things and come back to be by your side for an uninterrupted time." Once you do that, things fall in place. Always practice together because you can't be available 24/7 for anybody. You still have your own timings. You have your family time. Understand that.
thank you so much, ma'am.
Thank you.
Could we have the participants to present their case from the breakout room 3? I guess Aditya or Harish or Vrinda was there in the breakout room. Could you present the case?
Yes, I present the case. Good evening, ma'am.
Good evening.
Ma'am. So I believe in breakout room 3, it was case 1, the stillbirth case from Uttar Pradesh. So the case, yes. So the case was that a man carried his new still, they went for the couple went for a delivery in a private institution where the child was stillborn, and the patient, the private institution and the authorities there didn't respond in a proper manner towards this, and therefore the man had to go and lodge a complaint in the district collector office to get the proper response and get justice for what happened. They were not very how, I don't know the words exactly. They were not very helpful in this matter, then they should have been more emotionally aware. They weren't emotionally available. They weren't available for the patient, and this furthermore this led to the protest and all that. And so during the breakout session, we discussed that how can we know that this is a problem now. We saw that in a very recent incident in New Delhi, we saw that a case in the hospital, that the child was dead, and then they still charged the patient, the family, on the money for the care and all. So we discussed that should we have increase government surveillance into the private sector, or should we introduce a grief intermediate counselor, someone who is more able to communicate much better between the patient and the much better in delivering the news to the patient. And we had some conflicting views in there. So one of the participants said that it's not right to get more of the government influence in here, and one of them was in favor of introducing a grief counselor as acting as an intermediary between the patient, family, and the woe. And then another, it was a woe that the patient will always ask for a doctor to deliver such delicate news. So we should be introducing more life skills, and building up activities in the curriculum that we are currently in, the MBBS curriculum, MBBS or PG curriculum. So this was.
Do I give my opinion on this? Yeah. See, those of you who train abroad, either in UK or US, this comes as a part of your training when you do a post-graduation, whether it's RCOG or the AV board. They give you this as a part of the training, where breaking bad news is a standard station in the OSCE pattern. Okay. The point of not charging the patient is something as practitioners and also by the IMA we would never accept, because what happens is when you don't charge the patient starts feeling that you've done a mistake. Not every time it's medical negligence. Okay, even in the best of hands, the best of care, everything doesn't fall in place. There are certain areas which go beyond control, and medical care goes its own way even when everything has been right. There's something called as unexplained. It is a very tricky field, obstetrics. That's why it's called obstetrics. Okay, so it's very tricky. We need to understand. So once you say you're going to waive the field, the common thing that runs in the patient mind is these people have done some mistake, they've goofed up, that's why they're coming up with it. However, you need to understand the medication, the amount of hours spent on them, everything has been utilized. So they need to pay for it. But we can be empathetic in giving them discounts and doing all other things. That's a part of it. But when there is a stillbirth, how could we address it is right from the antenatal period, this has to be there. Identify the high-risk cases. Categorize them as a high-risk and low-risk. Even a low-risk patient can have a stillbirth. See, amniotic fluid embolism, cord compression. These are things which cannot be founded even if you have the best intrapartum surveillance available. Okay, amniotic fluid embolism is something which can just happen like that. You can even lose some other, let alone leaving the baby. Okay, So these are things which have to be kept. But if you're going to tell every pregnant woman that you can go through all this, everybody would run away. Okay, but we need to be, telling the patient every visit after she's 32 weeks, are you able to feel the baby's movements? Anything wrong with the baby's movements, you need to pick it up. You need to come back to us. So time and again, when you start retraining them, they understand that movement is very important. So something wrong with the baby, the entire family should be tuned to that. So when they come back with a complaint, they themselves know that something is wrong, they come back early. So these are all things which we have to keep in mind. And keeping a birth attendant during the course of labor from the family helps them also to understand how you have been attending, how your sisters have been attending, give them the compassionate care, because they are going through the worst phase of pain in life, which I don't think many men would dare even to get it done. Many of them with labor analgesia, some of them don't even have access to labor analgesia, they go through that. So being very empathetic to them at that point of time, giving them all the comfort, giving them the access to continuous monitoring of the fetal heart, looking at the variations of all of them will save a lot of us happening to them. Beyond that, when something is happening, we need to make them understand that we have given the best of care. Beyond that, this has happened. However, we will look into it. They will definitely have a lot of grievances. Sit with them, talk to them, see if there are some protocols that needs to be changed. Every bad news is not to be discussed and left. It is a time for you to sit and change protocols in your hospital. See to them that doesn't happen again. Yes, Aditya, you have something.
Yes, ma'am. Ma'am, I wanted to ask that as these incidences are more or less coming from private institutions, should we introduce government surveillance here, or should we have a system like research laboratories have the cross checks, and should we introduce such measures?
Yeah, I am into the Association of Obstetrics and Gynec Society of Chennai. See, the whole thing is, it is practically not possible because in the governmental sector, they already have enough work to do. And every single patient that you want to decide for a C-section, you can't wait for a permission when you are having a baby whose heart is decelerating. Okay, so it has to be with the judicious usage of a qualified person to take the decision and move ahead. What we are trying more and more is to have a team approach, not just a single doctor, because it may miss her eye. If you have a team of doctors, 2 of them or 3 of them, then the surveillance becomes much better. See, it is not the thing which is government is separate, private is separate. Mishaps do happen in the government to a larger extent because that is actually a place where you have a tertiary care reference. Okay, the ones which are mishandled or ones which are not being handled or ones which are denied treatment are the ones who go to the tertiary care centers. They're actually, it is more if you really look at it. But the thing with single-handed doctors and their organizations is they're alone, so they don't have the backup. So that is slowly changing today, thanks to the media hype that is being created with every small mistake that's happening. You have one YouTuber sitting, you have the entire team sitting with, the entire media bombarding the doctor, ransacking the place. All that is also happening today. So that has brought a lot of change into the way obstetricians have started practicing today. Or this is work as a team. So we know we are here delivering the best and stick to protocol. Whatever you do, when you're using a drug, see, recently in Chennai, we had a problem with one of the senior doctors. She had used Arabic pessary for preterm labor management. Arabic pessary is not legalized to be used in India, though it is FDA approved. So the answer was, why did you not do a circlage? If you had done a circlage, maybe you would have gone through a preterm labor. Why did you try a new protocol? So if that is a scenario, what we should do is we should sit with the patient, discuss with the patient. There is a drug which is new in the market. Would you like me to treat? If so, take a consent from them. Keep a copy of it. Always the consents have to be duplicate. Keep them. So this sort of practice will be better. Be very transparent. Give them the evidences which are available today. See, this is there. A study has been done. We are advocating this because this has been proven to be useful. So once you do that, whether it's a governmental practice or non-governmental practice, things remain. The purpose of having a continuous monitoring, a CTG and all is that the patient themselves appreciate, see, doctor, I see the baby's heart rate at 80. Is my baby, suffering? Is my baby getting into distress? So that's a reassurance to us. You have another birthing attendant in the form of a husband or a sister or a mother-in-law who is also seeing through the entire scenario with us. You can't wait for a government doctor to come and entrust us with the job at these situations. You have something, if you have to wait for a clearance from the government doctor, it is not practically possible, because we are seeing that for the late picked up anomalies who come to us after 24 weeks for termination, we can't do it. We have to refer them to a medical board. They have to get the consent, and then two doctors have to do. By the time they come in 22, 23 weeks, and we're not able to terminate in 24 weeks, by the time they come back, it's 30 weeks. They run from pillar to post to get things done, and when they come, there's nothing less than 20, 30 weeks. It takes them, definitely a month to do it. So for every single case, if you're going to go through that, every hospital has its own board. Whether it's 2 doctors, 4 doctors, or an entire team of 10 doctors there, they go through that, like how you have your onco board or you have a urology board, sit, discuss the case. This is what is happening in all setups today. We take up a case. If I had a near miss 2 days back, we all sit, we go through it, what went wrong, what are the protocols we should change, how should we do it again. So when you are coming for the next case, when you anticipate, the entire team, right from the staff nurse to your assistants, are mentally prepared to address it better.
Okay, ma'am. Thank you, ma'am.
Thank you.
Do anyone have any other questions? Yes, Harish.
When there is too much of scrutiny for the doctor from the media side or through any means, what happens is there comes defensive obstetric practice and the rate of LSCS goes up. Do you think the rate of LSCS goes up, or because that is also again discussed in the media and movies, and they say that if you go to a hospital, you will definitely end up in an LSCS. Such narratives are being framed. And as
Yeah.
a result of which, in Karur, I think we had an incident while a couple decided to have a home delivery instead of institutional delivery, and we lost the mother.
Yeah.
So, how to handle all these?
See, these things happen time and again here. See, what happens is the media hype is too much. One thing that travels faster than light is bad news. We have to accept it. Okay. The first thing is, we are always talking about doctors as if they're always standing with a scalpel ready to cut your tummy and take the baby out. It's not that way. We have the girls who go through structured training, birthing classes, Lamaze technique. They go through all sessions, their physiotherapy sessions. But then the slightest of pain, the first answer comes from the parents is, my daughter will not go through pain. What do? Number one. Then you have this astrologer come into the field who says only a child who is born at 7 to 7:15 will become the next Abdul Kalam. These are all factors. Okay. The next thing is the doctor, as you said, really all obstetricians do a very defensive practice. We see none of us have, induce a patient for tolak or VBAC. Only when they come well into labor, we try to deliver them, because anything goes wrong, we are going to be scrutinized more. This is again being discussed so much with the NHM board in Tamil Nadu. Luckily, we have a doctor who heads the NHM. Dr. Arun Tamaraj is there. Initially, he was also very harsh on us. Now he has got to understand the point of it, and he's also telling. So as doctors, from the government side, they also have the pick me number. Everything is put up there. So there's a lot of discussion between the government and private interface that's happening. So doctors, not just in this field of obstetrics, in every field today, they're playing a very defensive practice, because they do not want to go through the CPA, or they don't want to become, scapegoats in the media. See, one untoward incidents, the 20 years of goodwill is lost. So that's something all of us have to be very clear, that the secret of that is only group practice, group practice, group practice, following the ethical standards, not hiding. See, when you're transparent with the patient, explaining everything that you have done, at least one member of the family will understand you. Not the direct beneficiaries, but at least one person will understand you. Over a period of time, it seems to them.
Thank you, ma'am. Thank you so much.
Thank you.
Any more questions? Yes, ma'am. Okay. Thank you, ma'am, for your thoughtful and this compassionate session and your insights on this empathetic communication and ethical sensitivity in such difficult moments have really been important for an understanding of the patient-centered care, especially in cases of congenital anomalies and stillbirths. Thank you so much, ma'am.
Thank you all. Wishing you all a very good future, bright future ahead. Thank you.
Thanks, ma'am.
And now it is my privilege to introduce Dr. Gaurang Narayan, who is a final year junior resident in obstetrics and gynecology with a keen interest in bioethics, reproductive justice, and medical jurisprudence. He holds a postgraduate diploma in medical law and ethics from National Law School of Indian University, Bangalore, where his thesis on medico-legal issues in Surrogacy Regulation Act 2021 has been widely cited. We are truly honored to have you with us today for this session, sir, and we look forward for your insights. Sir, you're muted. Yes, sir.
Yeah. So, good evening. It is indeed my privilege and pleasure to join you guys for this interesting discussion. I would thank the SIMSOG team for extending this invite to me. And surrogacy is like a personally close topic. It's because that was my thesis for my law school degree, postgraduate diploma in medical law and ethics from National Law School, Bangalore. And to be honest, till date of around close to 25-30 research papers that I've contributed in, this holds the highest number of citations. And so it is a close topic. I look forward to this discussion. And personally, I know Porus for over 1.5, 2 years now. We work together as well. Thank you, Porus. Thank you for extending this invite or recommending to your core team to have me on board. And to the entire team of SimSoc, thank you for the smooth onboarding. It's been great. Like, you guys have been there always. I had doubts, or whenever you had to reach out to me, you were quite patient and very humble. Thank you so much. Thank you for the invite.
Thank you, sir. Could we have the discussion now from the breakout room participants?
Yeah, sure.
Can anyone volunteer from breakout room 1 who had the cases?
Brinda, would you like to speak on the case since you were in
Yeah,
breakout?
yeah, definitely. Actually, I joined it in the next. This was not my original breakout room. I just joined because my original one just got over early. Still, I'll do that. I think in my scenario, I mean, in my views,
Oh,
I think a man and woman, when they are undergoing divorce, should not be allowed to, get into surrogacy or anything. Once the divorce is done, then it's okay to proceed with whatever they're thinking.
Okay. Uh, anything else that you would like to add? Like, what are your views? I mean, we could do this two things. We could just share your opinions, or we could go ahead with the mock discussion questions that you guys have come up with, or just take it question wise. uh, I mean, I agree to what Vrinda just said, that ongoing divorce is a gray zone where you do not know if you will be together there, because there is a 50-50 game, right? You've applied for divorce thinking that you want to mutually separate, but then you might end up not getting mutually separate. One outcome, the other outcome could be that, okay, you guys, the couple or the intending couple, are planning to now mutually separate. So in that case, it is a gray zone, and it is important that the government prevents such a couple from actually taking up surrogacy as an alternative for conception or having their own biological kid. So it's a right point. But do you know that there are already provisions in place for this actually? I mean, this is a very contemporary case. There, here, mistakes have happened at multiple levels. So, the first level where it has gone wrong is even before a couple registers them for surrogacy, there is something called a certificate of approval, or the Form 2 of the Surrogacy Regulation Act of 2021 clearly states that they have to be the intending couple, have to be a couple. They have to be legally married for a minimum period of 5 years. Okay. And that they should not have their own biological kid, or even if they have a biological kid, it should either be an anomalous baby, or a mentally retarded baby, or a baby who had cancer, or that the patient currently has secondary infertility. There are a lot of clauses to it. So let us say you run a private clinic, and then a couple walks into your clinic asking you for to just a counseling, or they just want to know a cafeteria approach as to what are the surrogacy related options that they have. The first thing is your detailed history, because your history should be detailed as a physician to bring in that depth of the marital relationship, or the mutual relationship that a couple follows. Because yeah, especially after the baby Yanji case that happened in 2005, where a foreign Japanese couple had tried for surrogacy in India, and then they later abandoned the kid, and the kid did not get a Japanese citizenship also. After that case, which was a landmark judgment, the court these days are prioritizing the well-being of the kid rather than the well-being of the intending couple. According to the court of law, it is just the well-being of the kid and the well-being of the surrogate that matters. That's of paramount importance more than the intending couple. So because they have to uphold the legitimacy rights, they have to uphold the rights of the kid in the future to come, because a surrogate child which is not biologically born also to one of the couple has equal rights to inherit properties, for future decision making and so on. So the court takes into consideration a lot of these things, and that is why the first provision is your history has to be perfect. Second thing is they all undergo counseling. Okay. So it is very important that the couple undergo counseling, and through the process of counseling, what we tend to adopt something called a neutral non-directive counseling is what is recommended by the law. A neutral non-directive counseling, where you can use individual counselors to talk to the couple. That is when you would have easily found out that probably one of the couple is planning for a divorce, or that they are in the process of divorce. So you would actually never apply for surrogacy in such case. You would not proceed with the subsequent steps of surrogacy. You would now then stop here and directly would have called a legal counsel, for a legal resolution. There is a landmark case also. If you look at the Gupta case, that a couple who were planning for a divorce were called for, since one of them wanted surrogacy, they mutually decided, okay, at least for you I can do this much, as a part of settlement. They decided to hold on to their the proceedings of divorce until the surrogacy happened. So there are multiple things. So first of all, a physician counseling, then a proper psychologist's counseling, then a proper informed consent form where they have mutually declared it that they are not in the process of divorce. These legal documents would have definitely prevented this case from going for, so far, hypothetically speaking. But yeah, so these are all the provisions in space. And as you rightly pointed out, Govinda, it's a gray zone whether or not to do it. So as physicians, what you have to do is, a joint counseling of both the partners is important, followed by an individual counseling session. And you have to adopt this neutral non-directive counseling that is very, very important when it comes to all these things. And coercion will not work, because you should have legal checkpoints in place. They are there. Form 2 is there. There's Form 4 is there. There is an eligibility certificate. Until you get it, you cannot proceed with further steps of surrogacy. But again, there is a lot of legal loophole also here, because technically speaking, they are only in the process of divorce, right? They have not yet been separated, or the verdict has not come out that they are now mutually separated, or that the family court has granted them divorce. So legal loopholes always exist, in Indian context. presumingly, at the end of the day, it depends on your luck, how your lawyer will fight for you, and on a large more on how your judge who is benching that particular session is going to read the law, interpret it for himself, herself, or themselves. Yeah.
Thank you, sir.
Like, anybody has any other questions about this case? Like, if you have something, we can go ahead and discuss.
Raju, do you want to say your opinions on this case or contribute to the discussion?
Actually, whatever points need to be discussed, I think Sir has discussed. He has touched upon like every point in depth, and he focused on that importance of like taking a proper history. So I think I had he just ate without leaving any crumbs. He did a wonderful job. So yeah.
I'm sorry if I mean, it's the other way around. Did I cut room for discussion? Then please, I'm so sorry. I would like to listen more and then contribute.
Oh
Yeah, at
no,
least for
sir, no, sir.
subsequent cases.
Actually, it is much better. Like, just get a view from a, like a professional. And if we had something to add on to, like, I think we'll definitely open up. This format is really good, actually, sir. Like, please go ahead. That was just a compliment, not a sarcasm. It was a genuine
Thank
compliment.
you. See, on a large basis, I'll just explain one thing to you. There is something called a triangle test. You know how a law is made, right? You write a bill, group of experts sit together, then it is passed in both the houses, and then the bill gets translated to an act, and then the act obviously gets reformations. Like, the first bill came in 2019 for surrogacy, then 2021 the act came, and then 2023 they had the amended act of surrogacy. There is a lot of things, but what we take into consideration is, does an act or a bill or whatever, does it pass the golden triangle test legally? So what is this golden triangle test is, when you talk about medical legal issues, no, there has to be article 14, 19, and 21 that a bill or an act should fulfill. You know, right. Article 14 talks about right to freedom, 19 about your autonomy, 21 about your own perspective decisions. So, but then on a large extent, all of these things are interpreter related. I interpret it optimistically, someone interprets it pessimistically. For example, you see, if you take the LGBTQIA plus community, after the Navjot Act, a Navjot case that happened where they abrogated Section 377, made it unnatural sexual offense to a natural offense. What did they say? They said it is a man's body. He has right to love or make love or have, a cohabital relationship with any man or the gender that he wants to. It's a reproductive autonomy. I like someone and I am cohabiting with them. It's not your concern. It should not be your concern, right? So it followed Article 14, 19, and 21. But if you see that, the Surrogacy Regulation Act clearly does not do it. Like, they have omitted the LGBTQIA plus people from actually availing, surrogacy related services. Like, why would a person from the queer community not want to have their biological kid if surrogacy very well is an option for them? So when the same article 14, 19, 21 was interpreted it at one way and they decided to abrogate the act, the same was not considered in the when they were passing the Surrogacy Regulation Act, because somewhere they were so rooted to this concept of there has to be a biological man, there has to be a biological woman in order to rear a kid. They need, because at the end of the day you're having a kid and all that they are concerned is welfare of the surrogate and welfare of the kid, that the kid has to be reared perfectly and that the kid will need one man and one woman one father and one mother, irrespective of the duality in roles, the roles or role reversals or whatever happens in the future to come. They need that rooted concept. But will it answer this question? What if after surrogacy, after 5 years, the child loses father in a road traffic accident, or the child loses mother secondary to a breast cancer? Then your entire concept of having a father and mother is lost. So it's a very gray zone. The surrogacy regulation, the beauty of this act and why I took that up as my thesis topic itself was, there are absolute gray holes and it absolutely depends on who is interpreting what. Yeah.
Thank you so much.
Actually,
That was quite insightful to hear, especially about the Golden Triangle rule and the way different things are interpreted. Um, does anybody from the other breakout rooms have any question on the previous case, or we can move on to this case? I think this was discussed by Vrinda and Shantanu. So please, either of you could share your opinions or questions or whatsoever.
No, this was not the case that I had discussed before. I think it was the case three that I discussed.
Uh, okay. So I think Shravan, your room had this case. If that is so, then I think in that room it was Shravan and who else was there in that room?
Abhinav.
They left.
May I speak?
Yes, yes, yes.
Yes.
Please go ahead.
Actually, I was assigned the case 3. So technically, my case is actually the next one. So we discussed that case. The next one, like case number 3. Yes, this one.
So case two was in. I think case three was repeated in breakout room 1 and 3 probably by mistake. Uh, Karuna, do you want to just like take the discussion and then Gaurang could probably opine on case two,
Yes.
just for the sake of completion?
Yes. So case 3.
Case two,
Yeah.
right?
Case
Okay,
2.
case 2, sure. We can go with case 2. Yes, so it is a case. I haven't seen the case as well, but it is a case of custody delay for an incarcerated surrogate. So there was a surrogate mother who was jailed for alleged child abduction, gave birth while in custody, and intended parents petitioned for immediate custody, but the court deferred handover, citing medical guidelines, and the Supreme Court president allowed infants to stay with the surrogate for about 30 days for bonding and breastfeeding. The surrogate submitted an affidavit offering to relinquish the child, but the timing of separation remained contested. The Gujarat High Court considered both statutory law and child welfare principles. Judges emphasized postnatal care and surrogate well-being before final handover, while noting that the custody orders under the Surrogacy Act must be issued by a magistrate. The Supreme Court's guidance on infant search bond duration informed the decision. So,
Does anybody in the meeting have any opinions, or like we can do the discussion right here, I guess, right? So Raju, Vrinda, Abhinav, anybody?
Yeah, anybody who has an opinion or a stance, man, I would love to listen to your perspectives on this before like I could talk or discuss this further. Like anybody, what do you feel? I mean, on the other hand, man, to break the ice, I mean, I'll put it forward. Do you think it is important uh, to let the surrogate have access to the baby post delivery? For medical well being of the baby as well as the surrogate mother who's delivered, or believe in early bonding and then send an early transfer of the kid to the intending parent. What do you think? What do you think is right, and how do you place it?
Can I speak? Can I?
Yeah, anybody. It's an open
Yeah.
question.
I feel, the sword has two edges, right? I think what you said, the first part especially, it's good for the surrogate mother. Imagine the kind of like physiological turmoil she might be going through. 9 months you were there, and you just come and say that, okay, fine, yeah, bye. Now it's theirs. You have done your part, good job. I don't think, we take human emotions into play. We actually, I also, the other breakout discussions in the previous session highlighted a show that happened, in Tamil where it's called Niya Nana. I don't know whether you know it. It's like Satyameva Jayate, but it's still continuing in a short form. Let's put it that way. They take social issues and they talk about it. And in that, there was a surrogate lady who was called in, and she was saying that even now when I go to temple, I just pray for them. Like she has her own kids. She came into this because she was not well off, and some middle lady came and she was like emotional about it. They said that you're very healthy. You could make sure that other women can also experience motherhood, blah blah blah, and all that. But at the time when she understood what she was signing up for. But when the time came when she has to give the baby, I think even the most rational women out there would definitely feel that pain. Law might state otherwise. Let's consider the emotional quotient here. And like the very touching thing she said was, even now when I go to temple, I pray for my kids. I also pray for that kid. So, it says that like emotional thing that's there. She does not know who the baby is with. She does not know what is the baby doing, but there's that aspect to it. But on the contrary, I think that's why the surrogacy law was set up in a way that it has to be altruistic, but it is definitely not. So I think the law also needs to expand a bit. The law has to work tandem to what is happening in the society. Yeah, I think that's my opinion on this. I think I touched upon one side of it. Maybe someone else could open the other Pandora's boxes out there. Thank you.
Thank you, Raju. Uh, okay, anybody else? Any other perspective?
I guess if we consider the other side, is that if the surrogate mother gets attached to the child, it will be difficult for her to separate. And if she doesn't, interacts with her and all, it will be easier to her to move on. We can look at it in that way as well.
Definitely, we can also consider the trauma that might be on the kid, actually, right? So, the kid definitely needs to know who the mom actually is, right? Like, I don't know, you cannot have moms, I suppose, like you need a single person to bond with. So, I think from a kid's perspective, from a psychological perspective, I think it's better. You cannot have moms. I mean, obviously, going to a very reductionistic argument, you can go and say in tribal society, there's no single concept of mother. Everyone goes and takes. But in the urban setting, let's be very honest, a kid needs a mother. I look up to only one woman, and that's my mom. I don't look up to anyone else. Might be, in good faith, there's my aunt, there's my grandma, but mom is always mom, right? So from a kid's, I think I did not touch upon that perspective. So I'm just, just to be on the, just to tilt the balance, I'm just giving my opinion. Yeah, thank you.
That is indeed nice. I mean, it felt like a debate, and uh, okay. See, there are a lot of things to take into consideration. It's just not one thing, and at the end of the day, it again will go by the luck how your judge has decided to look into the glass based on his, her, or their perspective.
Can I
First
have
of
one
all,
more point?
yeah, sure, please, please.
The thing is that a 2-day old kid cannot recognize who his or her mother is. He cannot. Take his time to see. Okay, it's my mother. She's my mother. So I think that's not a matter of concern. If he or she doesn't meet his mother at the time of birth, it doesn't mean that he'll have some separation anxiety or something.
Okay. Uh,
I might be
so
wrong. I don't know.
uh, the let me tell you one thing, Brinda. As far as ethical, medical, legal debates on surrogacy is concerned, there's no one right. Okay, so each of you have been right at your instances. Uh, And obviously, let's not forget the fact that we are Indians, and we don't function objectively, we function subjectively. Okay. So that is something that we all have to agree on. And getting back to this particular case, what are the things that someone has to take into consideration is the postpartum health of the mother and the baby. This is very important. Now, let's say what the law says. The law has made it very clear. It is least concerned and interested about the intending couple. It is interested only about the surrogate and the baby. Now, let's talk about the health of the mother. A mother who is in already in the jail. Okay, she's delivered in the jail. You do not know how her conditions were at the time of delivery, what all she had to go through. Obviously, respecting the physiological and the pathological changes that surround surrogacy. Her postpartum, uterine remodeling. Though we consider postpartum period only as 6 weeks, but it is believed that complete physiological remodeling takes 12 weeks to happen. That is why for preeclampsia, we ask the mother to get tested again, check her BP after 12 weeks. Diabetic women, GDM, we ask her to check her sugars again after 6 weeks and 12 weeks. The 12-week hunch has come because the entire remodeling of your body, your physiological change, because the entire culprit placenta is out now, right? Everywhere the culprit is placenta. Now, the placenta is out, it takes 12 weeks to remodel. So it definitely takes a toll on the mother if she is not breastfeeding. Breastfeeding more than the benefits of the baby. Let's talk about the benefits of the mother here. She has to breastfeed for proper uterine contraction, for proper oxytocin access, for proper HPE access, for proper endocrinological functions to reboot. Also, all through in the jail, we do not know what her conditions were. Okay, whether she's bonded with someone, not bonded with someone, you cannot neglect peripartum mental health. Okay, peripartum mental health is very important. Postpartum blues are very common. When I was giving my NEET, I was initially preparing for PLAB, and then I gave my NEET PG entrance as well. And then when I was preparing, I realized क्या है, एक दो सवाल आने वाले हैं एमसीक्यू में, कुछ भी नहीं, काउंसलिंग लिख दो, बिहेवियरल थेरेपी, साइकोथेरेपी. But then I realized when I started working that postpartum mental health, when I became a resident, I realized that it is a huge table for discussion altogether. They are actual disorders. Okay, you have to take that into consideration. A woman in jail, she's already guilty of something. Now you're also going to throw the baby out from her, you're going to give it to someone else. It is going to take a toll on her mental and physical health. It is very important for a parturient to actually breastfeed her baby, and for her proper mechanics to revamp and develop. Now, coming to the baby again, breastfeeding is important. Formula feeds has its own disadvantages. Breastfeeding is going to be, that is why we vouch for exclusive breastfeeding, right? We are all canvassing for exclusive breastfeeding. But now you tell me one thing: does it end only with breastfeeding? What about the other conditions? What about her hygiene? What about her care? What about the nutrition? What about the quality of compassion that she is going to receive in the jail, which is also going to impact the bonding that she is going to share with the baby? Is she in a good living condition in the jail? Will the baby be taken care of properly in the jail? First of all, is she receiving adequate nutrition, that her breast milk is also so full of nutrition? Now, these are again questions to actually open up, the medical debate altogether. Now, coming to ethics, you rightly pointed out that a baby is not going to recognize its mother. So the baby can always develop the bond. Like there is this concept of early transfer. There was this case called Ashish Jain versus the state of Gujarat, after which the Supreme Court upheld that at least for the medical well-being of the mother and for the child, you can allow the baby to grow with the mother for 30 days, I mean the surrogate mother, and then shift it to the intending couple. Now, who decided that it is going to be 30 days and 30 days के पहले bond नहीं बनेगा और then 30 days के बाद ही bond बनने वाला है? It is a query. Okay, there is no scientific logic to it. There is no explanation for the 30 days. 42 days is still explainable because you consider the postpartum or the pure peril period to be 42 days. 30 days, I don't understand. Who decided that 30 days? Some illogical non-medical person. Coming to the legal debates, you always are interested in the best interest of the child. You want the best interest of the surrogate. So that is why Section 9(1) of the surrogacy regulation, the regulated, the amended act clearly says that a surrogate cannot become surrogate more than once. That is to uphold our bodily functions, reproductive functions, everything. And then there is Section 10 also of the act, which clearly tells you that there is something called a post-delivery responsibility contract. So at the time of surrogacy, at the time of embryo transfer itself, a surrogate is legally signing a paper where she is informed that these are your duties in the postpartum period. So post delivery, डे 1 में ही मैं बच्चा छीन के चला जाऊंगा, नहीं तुम 30 दिन तक देख सकते हो, तुम 20 दिन तक देख सकते हो, तुम 15 दिन तक देख सकते हो. You can breastfeed the child. These days, with the advancement of breast pumps, refrigeration, storage, there are breast milks, human breast banks available. You know, everything is already decided. And who decides this? The lawyer, the treating physician, or the obstetrician or the gynecologist who's planning the entire IVF process and surrogacy, and a trained psychologist. All three of them get to decide, and they are taking this consent very clearly from the intending parent, the surrogate mother, and the baby. So what if this woman has already signed some contract like that, which your case does not talk about, right? Because once you sign a contract, that is going to stand a proof of legal documentation for you, that is going to supersede any affidavit, because it's an informed relinquishment, which is going to ensure that there is some ethical clarity to this entire debate that we are doing. Okay, last but not the least, now in special situations, because there are always exceptions, there are always ifs and buts in the medical field, because we just don't deal with body, we're dealing with emotions, we're dealing with people, we're dealing with contemporary situations. In that case, what can you do as a doctor? Because the intending couple is going to come and tell you, will can also sue you that you were also a party to the legal contract that she signed. Now the court has given permission for her to take care of the baby for 30 days. Now I don't want to take the baby. अगर आज बच्चा दे रहे हो तो आज दो, नहीं तो दो ही मत. If someone tells like that, what is your say? That is where the court in the year 2023 came up with an additional suggestion that, like, you have medical boards for solving discrepancies and disputes of adoption and adoption related services, especially when you want to do that adoption beyond 24 weeks. They said if there is anything, something like this, any ethical intermediary in between that is going to happen, then the best is, as the gynecologist, tum apna haath dho lo, you play safe. Because I think I joined when that previous speaker was speaking, and what she told was right. One mishap and 20 years of your goodwill is lost. Why would I want it? Why, मेरे सर पे क्यों मुझे ताप लेना है? Why should I take all this stress and pain? I will just refer it to the medical board, and let the medical board, which has a third-party psychologist, a counselor, a radiologist, a medical board person, an NMC associated or local municipality associated doctor, a super trained gynecologist who has had good experience in the field, will all decide on this contemporary. And they will do, and that is specifically mentioned in 6(2)(f) of the Act, where you can revoke this particular post delivery responsibility contract as a doctor, and then say this is a special case and now you want an expert opinion, and let that expert opinion people or the board decide what they want to do, कि कितने दिन बच्चे को देना है, नहीं देना है, क्या करना है, क्या नहीं करना है. Last but not the least, for this case, let us say the Supreme Court said you take for 30 days and then you can hand over the baby. What is the guarantee that the baby is now fit? Nobody is talking about it. There has to be a discharge summary, of the baby. Like, let us be very clear, without a discharge summary, you cannot register birth and death in India. Like, home deliveries are still okay, but still you'll have to go to the nearest PHC, or the Daima has to take you to an ASHA worker, and then the ASHA worker has to verify and then tell the local CMO, and then the local PHC CMO has to issue some documentation of birth and death. So for this birth that has happened within the jail, who took care of that birth? Who supervised that birth? Was there a jail doctor? Is there someone who's going to give a postpartum fitness for the mother, or is there someone who's going to give a neonatal fitness for the mother? For the baby. There are a lot of things to discuss in this. It doesn't end there. So at the end of the day, there are 3 take-home messages. It's always medical welfare of the mother and the best interest of the baby that has to be considered. So you have to take into consideration the social, the mental, and the physical aspect of health when you're thinking of the baby and of the surrogate mother. And then uh, you can either play safe by having a pre-documented contract, as per section 10, or if you feel this is going to be a dicey situation and that these intending couple are going to play a ball game with you, then just revoke that particular contract and refer the patient and the case to the medical board. And I mean, anybody has any difference of opinion, or would you like to add something else? Is it something like that? Because the postpartum care that we talk about, no, also there is no structured postpartum care. It is an interim SOP care. Okay. My hospital will say normal delivery के patient को तीसरे दिन छुट्टी दे दो. तुम्हारे hospital में बोलेंगे normal delivery को 24 घंटे में छुट्टी दे दो. Right? There is no clear consensus guideline. There's no ACOG, RCOG guideline which says you discharge the patient at this much hours or these many days. Everything is interim SOP based care. So there are a lot of things to discuss in this. Yeah. I mean, I think this is what in crux I would want to present and not talk. Anybody has a difference of opinion or has any questions to ask? Or you feel that there's something different that you can tell?
Not really a question, but
Yeah.
was incarceration really necessary for a surrogate mother? Like, couldn't there be a clause saying that after pregnancy and after taking care of the child, the legal issues can be taken care of?
Um, See, not really. Not really. Because there is no law in provision which says that a pregnant woman who's committed a crime, like a pregnant woman who's naturally pregnant with her own biological kid, cannot be put behind the bars. Then where are we expecting that koi surrogacy or a surrogate mother ke liye ye sab sochega? Because there's no clear law like that. There are special provisions, like you can put them under custodial care, not put them into the prison. Then there is a particular subclause which says that if her health is deteriorating, then she needs to be under special observation. You can put her under Borister homes also. Okay. But there is no clear law which says that you cannot penalize a woman just because she is pregnant, or put her into the prison because she's pregnant.
Okay.
Yeah.
Could we move on to the next case? The last case of the session. This was one case that we discussed with Dr. Aqsa as well, about how single unmarried women, case 3, yep, how single unmarried women cannot apply for surrogacy, but then if it is a widowed woman or a divorced woman, she could. So we sort of already touched upon this, and I think Abhinav was in this room. So if you want to share your thoughts.
Hi, am I audible?
Yeah.
In this case, we are talking about how the legality behind surrogacy. Like in this case, a 44-year-old woman petitioned for surrogacy, but the court denied her request citing traditional norms. So it's very confused thing. Key, what is tradition meaning? Like laws being rigid, meaning to cater to the society, is based on like vague terms like tradition or whatever. So is that really a good thing? Is what you're discussing about.
See, that is what I think I told you in the beginning itself. We are so deep rooted with culture. Even the lawmakers who are sitting there in both the houses, they think एक बच्चा पैदा करने के लिए एक माँ और एक you need one man and one woman. You need a father and a mother. So there definitely does come a clash. You have to go with this traditional concept. That is why they have not upheld even marital rights. No, for the LGBTQIA plus community, because as per the Hindu Marriage Act, a man and a woman can only get married. We are not gender neutral yet. It's a far cry. Like you take the rape laws even today are clearly stating a man is said to have committed rape on a woman. I think all of you would have written this answer in your forensic medicine answer scripts. And the first line that you start writing is Section 375 defines rape as a man is said to have committed rape on a woman. And it's not vice versa. So we have not reached there. But then the only thing, like if suppose this had to be fought, in the court of law, if somebody had to discuss this, you can only talk about three important things here. First is, what does your constitution provide? Constitution provides you Article 14, Article 19, and Article 21. These are three important supreme articles that I told you, the golden triangle test that we always talk about, that will uphold anybody's autonomy, reproductive autonomy as well, because they are very, very, very important articles when it comes to such discussions as to why it is happening or what it is happening. Because it is very clear, Article 14 talks about equality. When you talk about equality, there is gender equality. Of course, people confuse equity and equality. That is a separate topic to ponder altogether. But yeah, it does provide gender equality. So Article 14 is there. Then you have Article 19, which talks about freedom, my body, my right, my freedom. I want a kid, I will raise a kid. What is your problem? As long as I'm able to provide you a sufficient proof of my proper stay, my proper finances, my proper physical health, that is important to rear a kid or raise a kid, the government should not be concerned. And the third thing is about personal liberty, right 21. Because I'm not getting married because I don't want to live with a person. I'm not getting married because probably I've not found a partner. I'm not getting married because I feel I'm ready to become a parent but not to become a husband or a spouse or a partner. It's my right to freedom to do whatever. So though these three articles in the constitution give you every right to do whatever you want to do in life, but these are interpreted by different people different times. Like you see, adoption is allowed for single women, adoption is allowed for single fathers. Why? Because they have taken these three constitutional provisions into consideration. But why have they not taken the same provision into consideration for surrogacy to have a biological kid? God knows. That is an unanswered question. I think it was a different lawmaker then and it's a different lawmaker now. Okay, you can just fight over it because this ethical paradox is going to continue. It is not going to stop there. Okay, and again, the same, you can extrapolate it to other things. Like it allows widows but not widower. Like a woman who's lost a husband can go for surrogacy. Why not a man who's lost his wife? Maybe he's not interested in marrying another woman, or we are still so socially judgmental that we have decided कि हाँ ठीक है, सती system है, ये system है, वो system है, तो probably widow will not get remarried. But शायद अगर एक लड़का की पहली शादी टूट चुकी है, उसकी वाइफ मर गई है, तो शायद दूसरी शादी कर ही लेगा because वो लड़का है भाई. These ethical paradoxes will never resolve. There is a lot to discuss because there is always a legal restriction and there is how do I put it? There is reproductive autonomy. They are not running parallel. At least not in India, they're not running parallel. You can draw parallels with countries even like Israel. Okay, like coming from a very different background also. Okay, UK, US have always been progressive. Israel, despite their ongoing conflicts, their own ethical, religious issues, have allowed single women, single men to undergo surrogacy-related services. Okay, so you cannot compare. So only thing you can do is, if we have to fight this case, you could have told to the court of law or pleaded to the judge that see Article 14, 19, 21 is there. Then there is something called the landmark Puttaswamy judgment. Like this is one judgment which can be extrapolated to the concept of consent, to emergency situations, Good Samaritan principle. You take any medical legal chapter pertaining to medical legal ethics, you will have this Puttaswamy judgment somewhere or the other. It was a landmark judgment in 2017, which said that there is privacy and there is bodily autonomy, which is of supreme importance in comparison to anything else. So when you talk about that bodily autonomy, you can still plead to the court of law stating that, it's my bodily autonomy and I want to wish to have a biological kid. and I don't want to marry, or I am not going, cohabiting or going physical with someone. So these are all few landmark judgments, few constitutional provisions which you can put forward and plead. But at the end of the day, how your lawyer is going to fight for you and how your judge is going to interpret will very much depend on whether or not these things are there. Because there was this recent judgment that a man is deemed to be the biological father of a kid and will have to ensure that he passes on lineages and his successive rights to the kid, even though the kid is biologically of some other man, because the wife has had a previous extramarital affair. This recent case has happened in Kerala. So when they were so progressive enough to think of reproductive autonomy of a woman in this case, the rights of an unborn child in this case, it did not still take into consideration the reproductive autonomy or the bodily choice that a man wants. Okay. So a very contemporary issues. So, I mean, if there's something else that you want to put forward, you can let me know.
So could you repeat the last point? I couldn't get you.
Uh, Okay, I'll just elaborate a little bit on the last point. The last point that I was trying to tell you is the court most of the times will consider something called the parens patriae principle. This is one principle in law which tells that the court also has to oblige, the government has to oblige, the surrogate has to oblige, the intending couple has to oblige because the child is innocent. An unborn child does not know anything. It did not decide to come to the world, right? Two people decided to bring it to the world, or a group of people decided to bring it to the world. The child is innocent. That's the parents patriae principle, which says that somebody has to take legal custody for the child. If not the intending parent, then the surrogate. If not the surrogate, then the local guardian. If not the local guardian, then the government. Somebody has to take care of a kid, of a newly born kid, right? The child is innocent, period. So in a recent case in Kerala, when so there was a couple, the wife had an extramarital affair and she conceived through that extramarital affair, but then she legally got married to someone else, and then the husband had filed an appeal that he does not want to take care of this baby because it's not his biological kid. But then the Kerala High Court overruled that particular case, stating that irrespective of whether or not you were the biological father, when you signed up for that marriage, knowing that this kid came from someone else, you have already decided to become the intending parent. And that now you are legally responsible for providing mental, physical, financial help to this newborn kid, and the newborn kid will also be entitled to successive rights from his property or whatever things or he has for the future. So when one high court could have taken into consideration this parents patriae principle and took into consideration 14, 19, 21 for the female who apparently wronged, who committed a wrong act socially, culturally, construally, the same different courts and governments have not taken this into consideration when they wanted to allow a single woman or a single father to avail services of surrogacy. So these are ethical paradoxes, uh, which only time will resolve.
Thank you for that, sir.
Yeah. See, at the end of the day, remember 4 5 things. It's autonomy, beneficence, null maleficence, justice, and accountability. These 5 ethical principles have to be tick marked. And as a doctor, you need to play safe. Because, like, when I took OBGY, my mom told me only one thing. My mom was not concerned ki, "Arey, mera beta OBGY le raha hai." She told me only one thing. That is one field where you're going to face maximum medical legal litigations. Are you ready to face? And I realized time and again after attending a lot of things that, with my experience, that good communication, proper documentation, and trying to find those subtle cues and early referral is what is going to save you from medical legal issues, because your hard work takes 20 years to come, but one wrong thing and it goes. And communication, especially in these where there are there is a confluence of interest, there is conflict of interest between people, there are tangents drawn between ethical, legal, medical, social perspectives. I think good communication has to help you.
Thank you, sir. Do anyone have any other questions?
And I think if somebody wants to learn the art of communication, as a medical student, as a doctor, there's this beautiful book I read, and in fact, I was fortunate enough to attend a 10-day workshop with her. Okay, and she's Dr. Indu Arneja. She runs an institute herself, and she's written this beautiful book called. Wait, I think it's Fundamentals of Clinical Communication, a step-by-step guide. I think something like that. It's a step-by-step guide, Fundamentals of Clinical Communication. It's written by Dr. Indu Arneja. You can read that book. It's a beautiful book, which will tell you how to talk, what is effective communication, how to break bad news, how to handle different situation, how to prevent violence against patient party. Because if your communication is good, I think violence will also come down. A lot of things. Yeah. Thank you so much, Simsok, for having me. I hope it was not monotonous or boring.
It was
Yes, sir.
absolutely lovely listening to you, sir. Thank you.
Yeah, and if you guys want to reach out to me for any other query or any other contemporary medical legal issue, just to spark up a conversation, you can always reach out to me on my Instagram handle. They have tagged the SIMSOG people have tagged me. You can reach out to me through that. Yeah. So I'll drop off. Thank you, Boris. Thank you, Divya. Thank you, entire SIMSOG team for having me, and it was a wonderful discussion. I'll take leave. Bye, guys.
Thank you so much, sir, for your insightful session.
Yeah. Bye.
Hello. To sort of wrap it up entirely, I think we have like one last thing that Divya will be discussing.
Yes. So we have a case discussion on DNR orders?
Hi, so the first case that we will be discussing today, am I audible?
Yeah.
Yes,
Yeah, you are.
So the first case that we'll be discussing today is brain dead mother after accident, life support and organ donation. So a 25-year-old woman, full-term pregnant at 38 weeks, sustained severe head injuries in a road traffic accident. Despite emergency craniotomy and an urgent C-section, her neurological function did not recover and she was declared brain dead shortly after delivery. Her baby was delivered healthy and admitted to neonatal care. After initial shock and grief, the husband and father consented to donate her organs. Her kidneys, liver, and corneas were successfully transplanted to several recipients, saving multiple lives. So, this case highlights the ethical tension between maternal bodily integrity, fetal survival, and the use of a brain dead pregnant woman as an organ donor. Doctors maintained life support until the fetus was safely delivered and facilitated the organ donation with family consent. So, this was our case, and this case basically sits at the crossroads of various things: maternal rights, fetal rights, and medical feasibility. And it gives rise to two main questions. Like, should a brain dead mother's body be used as a physiological incubator for the fetus? And the second question is that who holds the rights to decide once the mother is legally dead? Is it the husband? Is it the clinician? Or is it the state? So I'd like to ask. Uh,
Yes, so before we have this discussion on the insights, um, can we have any volunteer to just say what is meant by DNR? I know it's a pretty long session. It's like we just wanted to make it interactive, a bit interactive for this case.
May I?
Yes, sure, sorry.
See, DNR is do not resuscitate. So if the patient, when he is conscious without, in his full consciousness, without, under the influence of any person or any sort of drugs, he can give it in writing that in case, if suppose I happen to fall sick and all, do not resuscitate me, let me die in peace. Some old people say, like, don't poke and prod me. Like, it's as simple as that. So DNR is basically that. And if we have clear directives when the patient was alive that he or she should not be resuscitated, and we will not go with the efforts to save. We'll make sure that the person has a dignified death, and we will stop the resuscitation. It's my understanding, maybe superficial, maybe wrong. Do correct
Yes.
me.
Yeah, it is like more or less the same. Like the DNR, again, as we've seen in a lot of medical dramas, so we don't have a specific legal policy framework for DNR in India, but we do have in other countries. But in India, which is not a statutory law, but still we have something called as DNAR, which is just do not attempt resuscitation. So which was introduced by ICMR in 2020, which accounts for the shared decision making, the patient autonomy, and also the documentation. So this documentation, it is called as the advance directive, where the the patient's prior wishes are made it into a separate document, or like a living will. So based on which the medical procedure could be like, if there are any unfortunate events which would happen in the future, those could be managed, like then the person's views, like they do not resuscitate, will come into action on this one.
So,
Nisa,
yeah.
yeah.
So now that we've understood what is DNR, we come back slightly to our case in which it was mentioned that the organs of that lady was donated. So this type of situation, it challenges a very understanding of bodily autonomy after death and the moral weight of a fetus. So clinicians should act in accordance to the guidelines which are set by SOTA, Roto Noto Shoto, and ICMR brainstem based death guidelines. So, to elaborate on this further, I'd like to talk very concisely about what is THOTA. All right. So, THOTA is the Transplant of the Human Organs and the Tissue Act, which is implemented in 1994. To concise it even further, it was done to regulate the organ tissue transplant in India. It prevents any illegal trade, and most importantly, it recognizes brainstem death as a legal death. So, in a deceased donor or in cadaveric transplantations, there are certain steps that need to be followed before the transplantation. One needs to identify the patient as brain dead in the ICU. Brain death certificate needs to be provided by two independent doctors 6 hours apart, and then consent needs to be given for organ donation. And this comes to our second question, like who should be held responsible for the withdrawal of life support in brain dead patients? Is it the family? Is it the doctor? Or is it the legal authority? So I'll tell you about it that there is a legal hierarchy of system in India in which first it's the patient, but in such cases of brain death, there is absence of patient directives. So the family or the near relatives, next of kin comes first when it comes to consent. Then clinicians can certify brain death and provide medical advice, but they're not first and foremost to be considered. And then comes the legal body and the authority, and the legal authority, it intervenes only if there is a dispute amongst the family, an unrelated donor donation, and if there is any suspicion of malpractice or any legal violation. It's only then when the legal authority steps up for the consent based cases. So coming back further to our case, there was another question that arises in our minds is, in cases of pregnant mother who is like critically ill, the withdrawal of life support, do you think that her personal autonomy is truly respected? Or do you feel like the interests of the fetus, family, and hospital policies tend to override her own personal wishes? So I'd like our participants to opine on such question, please.
Could you just repeat the question, if you don't mind, just briefly?
Yeah, sure. So in cases of brainstem death and do you feel like the maternal autonomy is being truly respected, or And in absence of an advance directive or a previously written DNR, do you feel like the mother's autonomy is respected, or do you feel like the fetus's interest and the family and hospital policies tend to override her own personal wish?
May I answer, if you don't mind?
Sure, sure, sure.
Yeah. See, I'll just give my perspective. And nobody, no pregnant women is running around, assuming that, okay, in case if I had an accident and I happen to go into brain death, I should have a directive. That's first thing. So here, there are cases where not everything apply. This was an accident. This was an unfortunate event. Again, we can be as respectful as possible, but we're asking the family's consent, right? So right now, we assume, I think it's in the best assumption, as long as it's not some, like TV serial or something, we can assume that the family in large is in the support or is in the best interest of the women. So when they agree that, okay, like we are, we know we cannot save her, but in the best interest of the fetus, we'll keep her alive. I think it is doable. Like I think it is fine. Obviously, there will be always someone who will be offended and objected, but as you said, the tota, like make sure the act itself makes sure that if there is any sort of conflict, the legal body dives in. But let's say unanimously the family members agree on this, then I feel like we are not doing any sort of disrespect. uh, it's my opinion.
Yes. So it's not, nothing is right or wrong here. It's not a yes or a no basis. So in such situations, like the autonomy is ideally sustained, but practically it's just partially compromised. But it's the ethical responsibility of the medical team to carefully balance the respect for the mother's wish with fetal considerations, and alongside always documenting the process involving families and the ethics committee. Every decision that needs to be taken, along with the documentation for every reasoning behind those decisions that have been taken. So it's all about ensuring that the decision is transparent, well informed, and ethically justified. Another question that arises in cases of DNR for pregnant women is, should the gestational age be a determinant for external support? And for example, I'd like you all to refer to a very infamous case of Miss Melanie Munoz. It took place in US, in Texas. So in such a case, the mother was put on external life support for a prolonged period of 8 weeks. And it was in the absence of an advance directive of the mother. And what happened was, after the child took birth, there was this fetus faced severe complications due to prolonged lack of oxygen before the mother was considered brain dead. So this uh, imposed severe emotional, financial burdens on family itself. So should the gestational age of the fetus be a determinant for external life support on the mother? Or uh,
May I?
yeah, sure.
Uh, Actually, I don't know. It's a very it's not a matter of medical, but it's a matter of like emotional debate. Like there is no arbitrary cutoff where you can just say, some people might say that the moment you conceive, the baby is alive. Some people are like, oh, you look at, I think this argument we can draw parallels with what is happening in America right now, right? When they talk about abortion, there are doctors who are against it. And you look at the kind of statements we make. I go in there, I put, and I pull out, it's probably an arm. I go out, and the way they say it, they talk as if, like they're ripping off your or my hands. So they know the way how they are clever with their arguments, right? So I think it's the person who's advocating. If a person is clever enough to advocate, he can even advocate a zygote or to be alive. But if a person is smart enough to advocate that okay, see, at the end of the day it doesn't matter. Well, I think it depends on the shrewdness of who is the advocate. actually. Might seem a bit odd, but I think it's that way. So as you said, it's not black or white, it's shades of gray. And we just can't draw an arbitrary line. It depends on the family whether you respect what they want at the end of the day. In this case, yes, I have heard about it. They did not want the lady to be kept. So, you might side with the family and their cause. And also considering the fact that the baby was also having injury and prolonged, brain injury, I think it might be, I might tilt towards the family, but I think every case has to be evaluated. It's a case to case basis. I feel there's no arbitrary cutoff. My opinion. Uh, you might add on to it.
Yeah, so basically, when a mother is considered brain dead or unlikely to recover, the continuation of the life support is primarily for the fetus itself, right? So the medical team must weigh the expected fetal outcomes against any potentially invasive interventions which are to be done on a mother's body. So generally, as we all know, like a fetus is considered to be viable at 24 weeks of gestation. So before this point, the chances of survival outside the womb are extremely low, and keeping the mother on a prolonged life support may only prolong the suffering and emotional and financial strain on the family. But as we know, there is no law in India that prescribes a fixed duration of life support based upon the gestational age of the mother. So a practical guideline needs to be followed. For example, like for early pregnancies, like before 20 weeks, it is generally considered ethically acceptable not to prolong life support solely for fetal survival, especially if maternal wishes are well known. And for later pregnancy, like beyond 24 weeks, sustaining life support may be justified to allow the fetal viability, but it needs to be carefully monitored so as to keep assessing regularly the fetal outcome, balancing the fetal health and maternal dignity and the resources of that family as well. So, as I said before, there is nothing as one size fits all. Like each case needs to be evaluated, like individualistically taking account into maternal wishes, gestational age of the child. But our goal should always be to respect the maternal dignity and minimize the harm both to mother as well as the fetus. Now, I'd like Divya to opine and proceed further.
Yes, yes, it was absolutely right. Like whatever you were discussed, yeah. So based on that case, again, the maternal life is also more important. The fetal viability is more important rather than just maintaining the ventilatory support is to just as the maternal autonomy could be compromised in this case just to you maintain the fetal viability, and if in that case that couldn't be made, then yeah, then they have to again go for the potential organ donation in that case. Yes. Yes, Harish.
So, what I feel is like when we talk about viability, so we have different gestational weeks for different countries, right? And this viability we decide based upon the the NICU setup that that particular country has. So the more stronger NICU you have, I mean NICU you have, the more earlier you can deliver. So the concept of viability is itself not very universal or standardized for that matter. Second, I feel that in that case that happened in Texas, I think it comes from a place of deep religious values rather than the family being emotional or trying to save the fetus and all that. Uh, Especially in the US and in most of the Western countries, the the issue of abortion is so very politicized, and most of it comes down to one thing, that is religion. So I don't think as far as a secular country like India is concerned, we need to really think on that ground. So that is my opinion.
Yes, absolutely. Like again, the religion basis is still like based on the secular country in like India. We do have the opinions on like maintaining a ventilatory support or not having it. So yes, that is also a major role in this case. And coming to that viability, like the NICU setup, yeah, that's one is also like I do opine with that. Yeah, NICU setup would vary with every other country. So the more they could maintain the fetal viability and to just not avoid the complications, the better the the DNR could be like prolonged. Yes, that's what I would opine upon.
Yeah, also in that Texas case, it was backed by a law there because the family had not consented to the prolongation of the life support. It was the law because it was the hospital's decision that to prolong the life support. It was backed by a law stating that no mother, pregnant woman should be withdrawn of any sort of life support. So this gives rise to a lot of ethical issues itself.
Yeah, that is what I'm saying. That law itself comes from a place of deep religious belief. Texas, U.S. Conservative politics, etc. It comes from very, patriarchal religious ideas. So I think the law is itself very outdated, and that is my opinion. But it is for them to decide for their country whatever is best. But if you ask what I will have in my country, definitely more progressive values. We need not, compromise on maternal health for the outcome of a fetus that is not born at all.
Divya, you may take over.
Yes, the opinion on that was good. And anyone else wants to opine on this case on whatever like the topics we were speaking about?
Also, since we're sort of towards the end, after the word of thanks, if you want to give us feedback and all of that, that's welcome too. So we could do the word of thanks now and then proceed.
Yes. So, as we bring today's workshop to a close, on behalf of SIMSOG, we extend the heartfelt appreciation to our distinguished speakers for their time, expertise, and thoughtful guidance throughout these sessions, and our sincere thanks to every participant for engaging so meaningfully in these case-based discussions and helping create a space of shared learning and reflection. Thank you once again for being a part of what went wrong, and we look forward for continued participation in future SIMSOG initiatives. Thank you so much, everyone. And yes, you can share your feedbacks now if in the session.